Good morning, everyone, or good early morning to those of you on the West Coast, and good evening to our friends from Coop in Norway. And who knows, I think it's 2 a.m. in Australia, but hello, everyone. We're happy to kick off day 2 of NaRCAD 2022. For those of you who sat with us yesterday, this will be a quick refresh. For those of you who are just joining us today as your first day, we're kicking off our conference today, reminding you all this is our 10th annual International Conference on Academic Detailing. So it's a particularly special year, and we're glad to have you with us. Anna, let's talk about some of the things we got to keep in mind as we go into today.
Yes, welcome to day 2, everyone. We are in for a great day. So we'll breathe through some of the housekeeping. If you were with us yesterday, this is a refresh, but please turn your video on so we can all see and interact with each other in a visual way on our virtual platform. If you'd like, adjust your view to speaker view so that you can see the slide deck and the presenter side by side. Please keep yourself muted when you aren't speaking. And please also make sure your name is correct on your Zoom screen with your pronouns listed if you're comfortable, so we know what to call you. We will be staying on time throughout the conference to give all speakers their allotted time to present. Please keep an eye on the chat box for any updates from NaRCAD staff about any adjustments to the agenda. As we did yesterday, please use the chat box to ask questions and network with other attendees. We encourage you to ask the presenters any questions that you have. We'll do our best to get to all of those questions. And please do continue to share links and resources and insights in the chat. Please remember to keep any patient stories you share throughout the conference anonymous. And remember that we'll automatically add you to our mailing list if you're registered for the conference to keep you up to date on all our offerings and our news. If you'd like to opt out, please let Anshul know by Friday. And finally, please reach out to Anshul if you need any technical support today on any of the things we just mentioned or anything else.
Thanks, Anna. All right, let's talk about what's coming up today. Very, very exciting program for day 2.
Yes, a great program for day 2. So we are about to wrap up our kickoff and hear from Dr. Jerry Avorn for his annual AD talk, and Mike will introduce him shortly. Then we'll hear from 3 presenters during our field presentations today. We have presenters sharing about their AD innovations from Norway, from Wisconsin, and from California. We'll have a 45-minute break just like yesterday, and then head into breakout sessions. We have 3 awesome breakout sessions, one on applying lessons learned from a rural state to diverse geographies. We have one on team building and one on developing materials for both virtual and in-person detailing. And we can show you the links and the descriptions and all of that a little later today. Then we'll have an afternoon break and wrap up the day with a panel on capacity building and the train the trainer model.
Sounds good. All right, we're going to get everybody back on Poll Everywhere. Anna, let's talk about how to do it.
All right, so pull out your phones and send a text to the number 37607 with the word NaRCAD 1108, and you will be entered into our conference session.
We'll give you a moment to do that. All right. And once you've joined, Anna, if I am correct, you will get that little black box on the right, or white if that's how your settings are set, that says you've joined NaRCAD. So let's test it out and see what we got going on. What's one word you would use to describe the past year, either work or otherwise? All right. Let's see what we have. I'm going to reset this. Filibuster. Okay. Busy, crazy, great, family, learning, change, health. Let's see. We have a bunch of busies, a bunch of challengings, a mess, bananas, problems, exhausting, hot, yes, controlled, express, rewarding, blessed, transformational, a blur, hectic, joyful, motherhood, health, more problems, loss, learning, overwhelming. Yes, there is a lot here to be thinking about. Thank you all for sharing. And when we're thinking about exhausting, when we're thinking about transformational, and when we're thinking about continuing to learn, and also think about everything that's going on in the world, I see some of you talking about things like grief, politics, the state of the climate change. There's a lot to think about. And that's why it's really going to be lovely to transition to, there we go. We're having just a little glitch here. Apologies. And it looks like we're having a little bit of a glitch. Apologies. So we are missing the title page, but luckily we are introducing someone who does not need a title page here. Mike, please take the reins and introduce Jerry Aborn. And Jerry, we'll ask you to say your title aloud when we pass the mic to you.
All right, thanks, Bevan. And we will, as with any effective academic detailer, we will roll with the situation and make sure that we end up with effective communication. And you know you're going to get effective communication when Jerry has the podium, because that is one of the many remarkable characteristics that has defined his career. When I made some introductory comments yesterday, I talked about creativity in terms of our community. I talked about the breadth of things that people have done. And what's really striking when I thought about introducing Jerry this morning is that creativity and that intellectual breadth really is something that he embodied from the first work 45 almost years ago, when the initial projects that started the field of academic detailing first developed. It was the ability to think creatively about how to put different elements together to come up with this new idea. Was the breadth to pull in different methods, including some groundbreaking use of data at the time to evaluate those initial studies that basically created the groundwork that has led to what is now our 10th conference, our 12 years of being here, and of course the many other academic detailing programs around the country and around the world. And so while I know today Jerry's going to talk about a lot of both new ideas and historical precedents, it's well worth it for any of our newer attendees who haven't been to the conference before to go back to the NaRCAD website, to look in the archives and look at some of Jerry's original articles. You can even go back to his book, Powerful Medicines, from about almost 20 years ago, and just to see the creativity that leads to new innovation and to be inspired by it as we think about where we can go as a field. Now, the remarkable thing, of course, is that for Jerry, academic detailing is only one of several areas in which he's been an innovator, but it's the one that we're really learning from today. So you'll see in our program book his biography, his amazing record of accomplishments, well over 500 papers in the medical literature, a long-standing professor at Harvard, the creator of the Division of Pharmacoepidemiology and Pharmacoeconomics, where I spent my whole career until last year, and where NaRCAD was founded when Jerry and I got that first grant a little over 12 years ago. So it's a breadth of experience, a creativity, and a spark that remains just as bright 40 plus years after coming up with the idea, that always makes it such a treat to have Jerry here in this sort of this central sort of keystone part of the conference. On a personal note, he gave me my first real job and has been a colleague, a friend, and a mentor for well over 2 decades. And so it really is an absolute delight to be able to hand the virtual podium over to him once more.
Wow. Michael, thank you. Oh no, Kara, can you tell the man to stop? The gardener just arrived. Can you tell him to stop? The gardener blowing the leaves has, at the very moment that Mike handed it over to me, started blowing the leaves, and we're gonna tell him to stop so that I can hear myself talk. Oh, good, thank you.
If anything could be more more fitting for what we've all been accommodating to. All right. Anyway,
Right.
Back to Jerry.
Right. Wow. Yeah, I agree with Charles's comment that leaf blowers should be banned. But it's remarkable the way he was able to time the beginning of the leaf blowing exactly to the point when Mike finished that very generous introduction. But my wife Karen has waved him off, and hopefully they will not start again while I'm talking. If there was some Zoom control for stopping blushing, I would use it, because Mike, that was a very kind introduction. And all I can say is on my end, it is just so gratifying to see what a fantastic job you and the rest of the NaRCAD team have done over these many years in building up the program and in creating this annual meeting that brings people together from not just around the country, but around the world. And it is so gratifying to see how well the work has been carried forward by not just the NaRCAD team so well, but also everybody on the call who is doing this work around the country and the world. It's about as great as one could possibly hope for in thinking about a career legacy. But without further ado, but with repeated thanks for that very kind intro, let me begin with the talk. The title slide, which I'm pleased to see has been resuscitated. Transmitting good evidence well saves lives, and the opposite is also true. And Bevan, if we could go to the next one, please. You should always expect a second slide, which is disclosures of any possible conflict of interest. Mine is very simple. There aren't any. When I set up the division of pharmacoepi that Mike mentioned at the Brigham and Harvard Med School, we set up a policy that none of us would accept any consulting dollars from any drug companies. And I'm pleased that even though I have handed off the division to Sebastian Schneeweiss, that policy is still in effect. It is also true at Alosa Health, which many of you know about, which is our not-for-profit academic detailing organization, which also not only accepts no dollars from anybody in the pharmaceutical industry, but also makes sure that all of the staff and our physician consultants and materials developers also don't have conflicts of interest with industry monies that they accept as consultants. Alosa, as I said, is a nonprofit, and I don't get paid for any of the work that I do in any academic detailing activity, so I can talk about how great all of this is and everything you're doing without having someone think that I'm just trying to line my pockets with a business on the side. Next slide, please. Okay, let me present you with a case study of a city facing an epidemic. The patient zero, who was eventually defined as a previously healthy man who had been traveling into another country, came to New York City, was hospitalized, did very poorly in the hospital, and died of his viral illness. The authorities were afraid that that could touch off a huge spread of this extremely contagious virus all over New York and beyond. And in response to that, city authorities mounted a huge public communication campaign to encourage everyone to get vaccinated. There was a safe and very effective vaccine. The mayor was injected publicly by the city's health commissioner. Police volunteers and firefighters went door to door urging people to get the vaccination. The president happened to be passing through town, and he got the vaccine in public view, as did Anthony Fauci. Next slide, please. That went very well. There was contact tracing of the kind that public health officials have recommended for generations to find, isolate, and inoculate people who had been exposed to the initial infected cases. Public health officials immediately did a massive educational campaign about the threat, about the virus, how contagious and potentially lethal it was, and that it was really necessary for everyone to pull together and to get the vaccine as quickly as they could. And drug companies and the Public Health Service worked together to produce millions of shots of the vaccine in an extremely short period of time. Next slide, please, Bevan. Within 2 weeks, about 5 million New Yorkers came forward and were vaccinated, and another million shortly thereafter, the largest vaccination campaign in the nation's history. In the end, only 12 people were infected by the virus and only 2 of them died. The epidemic was declared over just a few weeks later in late April of the very same year. This actually happened. Next slide, please. It was in 1947, and the disease was smallpox. The president who was so proud to be inoculated in public was Harry Truman. And when Fauci got his vaccination, which he did in that particular epidemic, he was only 6 years old. And so what was different then from now? And I think the main thing I want to talk about in the few moments we have together is that this was a great example of communicating clinical information clearly, accurately, and compellingly without any kind of political or cultural overlay. There was a well-functioning public health infrastructure that was able to be mobilized and respond. People trusted their political leaders and medical experts, and as a result, hardly anyone died. And what can we learn from this in relation to academic detailing and our collective goal of transmitting information? You know, it's sometimes said that, well, you know, it's nice that you all are into transmitting information about treatments and preventive measures, but, you know, the real muscle comes from discovering new drugs or doing direct patient care. And while those are obviously extremely important, the point of this story is to also say that transmitting information can not only be incredibly important, but also a matter of life and death. Next slide, please. So COVID-19 actually gave us, now that we can begin to look at it, we hope, at least in part through the rearview mirror, an opportunity to learn about good and bad information transmission. We normally, as you all know, don't get to do randomized controlled trials of health services interventions, but COVID gave us a chance to show the effect of good communication and bad communication of clinical evidence in a dramatic and perhaps once in a lifetime kind of way. And it was, while not randomized, it was sort of a controlled natural experiment in that all over the country and the world, it was the same virus, more or less, different variants, but pretty much COVID-19, the SARS-CoV-2 virus, the same vaccine and drug treatments, more or less, at least in the US, and everything was free. So we can, in a sense, control for the effect of economics and affordability, and then ask, well, what can we learn from how well that rolled out and how the problems that we saw might have been avoided. And it was a lot about information. The brilliance of the development of the vaccine cannot be overstated. It was a complete tour de force scientifically, and you know, we all should be in awe of the fact that in less than a year, a previously unrecognized virus was identified, and then an mRNA vaccine and others were developed that were frankly much safer and more effective than the flu vaccine and many other things that we use all the time. And that should not be underestimated. That was incredible. And the other caveat I want to put in is that as we talk in a moment about the role of information in getting people to either live or not live as a result of this kind of natural controlled experiment, we never want to underestimate the fact that a tremendous amount of the disparities in who got sick and who died has to do with inequities in the healthcare system. And the fact that access, although the meds were all free and the testing was all free, the limitations of access on the basis of race in our systemically racist healthcare system and poverty and elderly people in institutions, I don't want to minimize the effect of that. But having said that, let's talk about for the rest of the country that was not subjected to that kind of prejudice and disparities, there also are lessons that can be learned about the effect of information. Next slide, please. Okay, a museum of what can go well and what can go wrong. So as I mentioned, we got this dramatic new vaccine, and sometimes we forget that it was really built on the basis of many, many years of publicly supported research. And our work in the Division of Pharmacoepi and in its portal division has looked carefully at that. I won't go into it now, but a lot of the medications that we use really rest on the shoulder of public funding, particularly through taxpayer dollars to NIH. And why drugs cost so much is often a head scratcher in relation to that, but that's not for today. The communication of accurate clinical information was remarkably poor. And this is, of course, what we all think about all the time in our academic detailing work. And beyond that, we had the astonishing communication of totally false information in the middle of this public health crisis. We all are aware of hydroxychloroquine, ingesting bleach, taking ivermectin, and somehow these became issues that lots of people were talking about and actually doing, which is, of course, the last thing we needed in the course of a widely fatal pandemic. And again, this is about what happens both on the good side when you communicate good information, and on the bad side when you not only don't communicate the good information, but you communicate the bad information. The FDA had some of its lowest hours during this. The commission of the FDA was hauled into the White House to announce that the hydroxychloroquine had been granted an emergency use authorization, and then to tout the use of convalescent plasma. This is the commissioner of the FDA. And that people who've had COVID ought to go out and roll up their sleeves and give plasma. Turns out that didn't work. And I think that left a scary precedent in the minds of many of us about how could FDA get things so badly wrong? And of course, we never were real strong on public health in the US, unfortunately, despite the very good people that are in that field. It's horrendously under-supported and poorly organized, and that was on full display. There's an old sentence that when the tide goes out at the beach, you get to find out who's been swimming naked. And we had a lot of naked swimmers in this pandemic. Next slide, please. Okay, so as a result, and this is where some of the data that have been collected since then have really been striking to me, it's been estimated, and I think this is really the case, that by the beginning of this year, the likelihood that a person would get sick or die with this virus that caused COVID was shaped more by the transmission and acceptance of information about the virus and its management, including the vaccine, than by the properties of the virus itself. So the information infrastructure, the communication and education infrastructure ended up by this year playing a larger role in whether a given person was going to live or die than the nature of the virus. And there are two interesting studies that have been, of many that have come out, that have studied this. There was a paper in The Lancet earlier this year that looked at a cross-national study of 177 countries in which they had previously measured things like trust in one's countrymen and trust in the government, as well as a lot of other health-related questions. And it turned out that those trust variables were bigger predictors of, whoops, I think we might have gone to, bigger predictors of the risk of death and the rate of death in that country than were other kinds of things that I've listed here that you would think might have been determinants of COVID death rates. In the US, people have looked at voting patterns in each county and have found that they predicted COVID death rates after adjusting for other factors that you'd want to make sure you adjusted for very, very strongly. And so these are things, it's not the virus, it's not the vaccine content, it's about the nature of the communication and education. And again, I don't want to dismiss the importance of disparities in access, but even when you control for things like socioeconomic status, these turn out to be big predictors. So the quality of clinical information that is transmitted can either save lives or increase risk. And that's not just for COVID. Let's continue with the next slide. And these are phenomena that in a much less dramatic way have been observed for other diseases. We just did not have this incredible sort of bouillon cube of experience where everything is kind of concentrated down to a couple of horrible years. But in a way, we've known for years that diabetes, blood pressure, cardiovascular disease, HIV, maternal and child health, and many other conditions, the quality of what doctors and patients know about these conditions turns out to be a very, very important predictor of whether or not people succumb to these conditions, as well as I note at the bottom, access based on socioeconomic status, race, and age. Next slide. So our goal in academic detailing, as all of you know so well, has always been to close the gap between actual practice, which I think of as being sort of here, and the best available clinical evidence, which I think is here. And we always try to sort of raise the level of actual practice to try to bring it up to the quality of evidence that exists from the very best possible science, whether it is lab work or clinical trials or epidemiologic studies. As I said, we've got now accumulating evidence that it was the information transmission that caused hundreds of thousands of probably preventable deaths. And that's been modeled out in a variety of intricate ways that are pretty compelling. And we see this all the time in medicine, even when we are not dealing with the pandemic. So it's not enough to just have effective and safe drugs or other treatments out there. They have to be projected into the healthcare system and into the lives of patients. And this is what all of us are about. And as many of you have heard me say, and I've called it Avorn's sixth law, although I don't know what all the other Avorn's laws are, but one of them is certainly good evidence does not disseminate itself. Next slide, please. So one way is academic detailing. And I think of it moving beyond COVID and just thinking about a lot of the other clinical topics that all of us work on. I think of it as kind of a hypodermic needle or a transdermal patch. It's sort of a knowledge delivery system to take what may be a perfectly effective piece of information, just like a perfectly effective drug, and make sure that it actually gets into the patient or the doctor or the system. And we all know if you don't just show or photocopy your email a drug to a patient and expect that it's going to have an effect on them. And the same thing is true of information. And the knowledge delivery systems that all of you and us are working on can be studied and evaluated to make them work better. It's always nice when we can do randomized controlled trials. And I think the VA system that Melissa Christopher has led has done some very impressive work in studying.
It is not lack of.
Hi, Mandy, you're on non-mute. Okay. So I was talking about Melissa's and colleagues' VA system, which has done a great job of studying these outcomes, but there are other ways of looking at things without being able to do randomized trials. And Mike mentioned rapid cycle evaluation designs in which one can try to do something on the fly in a real operational program and learn how well it works. Next slide, please. Okay, so where are we now in the fall of 2022? Mike was helpful in coming over back from BU to help teach in a course that we now offer out of our division of pharmacoepi at Harvard Medical School every October, called Medications and Evidence. And I try to get the students motivated by telling them that the course was 50 years in the making, in that it had its origins back when I was a first-year medical student in their shoes, and was wondering, when do I get to hear in the medical school curriculum about how to read a paper and know if it really is true, how to think about all the different things that shape patients' outcomes. And then there were a lot of other topics that I wondered why isn't in the Harvard Medical School curriculum more than 50 years ago, that you could probably think of the same list as I will enumerate, that is beyond the scope of our discussion today, but it's everything from nutrition to substance abuse to human sexuality to ethics to death and dying, and all the things that really are not there much in the medical school curriculum. But we focused in this course just the last month on how do you think about medications? And I often think of something that was said to me when I was a student by a wise professor, which is about half the things that we teach medical students today are not going to be true once they are in active practice. We just don't know which half. And in a way, it undergirds my belief, which is related not just to our course, but also to academic detailing, that probably the most important thing we can do in training any healthcare professional, doctors, nurses, pharmacists, anybody, is not just cramming their heads full of facts, but helping them to think about data. How do you know what is reliable information and what is not? And the facts are going to change. And the way we manage this or that condition is going to be dramatically different in 10 or 15 years than it is now. But what will not change is the ability to think critically about evidence and how to transmit it. And that is really the mission that so many of you are engaged in academic detailing. What is sobering is I had one-on-ones with each student and asked them, so how much of this critical reading of papers that we're doing, where we'd have a journal club and a small group would meet with the faculty and talk about a particular assigned paper from a journal, how much of that have you had before? And an alarmingly high proportion of them said, well, this is the first time. And these are third and fourth year students at Harvard Med School. And I mention that because it may be useful when you are and your colleagues are going out to talk to doctors. a scarily large proportion of them may not have actually ever been walked through. Was this a good study design? Was this an observational study that's not reliable? Was this a randomized trial that was not well randomized? And all the things that we all talk about in developing our educational interventions may actually be news to a lot of the doctors you're talking to. So you will need to figure out a way to communicate to them why that study that showed such and such really is not a great basis for practice, and why this other study is much more reliable. And I know that in our work at Alosa Health, it's always challenging to try and get to the punchline about why that study is not a good guide to prescribing, especially with an audience of doctors that we know will maybe never have heard these issues. So that's kind of scary, and I don't think Harvard is particularly worse than other places. I don't think it's particularly better either. And just kind of know your audience and be aware that you may need to sort of slip in some methodology 101 in explaining to them why what you're telling them makes sense in terms of their practice. In just the last week, we have seen new CDC recommendations, as many of you will know, about opioid prescribing. And what's very important about that and relevant to our conference this week is that the recommendations change. The experience with the first round of CDC recommendations from maybe 2015, 2016, was that they seemed to make sense at the time, but they led, as many of you who were doing opioid-related work, led in a kind of imperfect translation of those guidelines to excessively aggressive tapering or cutting off of patients from their opioid meds, and other things which in the fullness of time we've realized were not optimal. And good for CDC for taking a stab at this that many years ago, and good for them for looking at it again 6 or 7 years later. But in fact, this is something which is a key role for academic detailers. That is for two reasons. One is we're often looking over at Alosa Health at kind of what I think of as doorbuster arguments of, going to a doctor and getting in the door and, having them say, oh, I've been managing pain or diabetes or hypertension, for 30 years and you have nothing new to tell me, and to point out that actually, yeah, there are these November 2022 CDC guidelines that are new and different, and you may not have had a chance to read them cover to cover. Let me help you know what they say, because that's part of the service that we can provide to you as an academic detailer. And that's a great way of not just getting in the door, but starting a conversation. It's also, I think, a great example of why the interactive approach that you all engage in, and which is really at the essence of what academic detailing is, why that is such an important tool for educating people. You will, if you are visiting on an opioid topic, or frankly, any other topic, but in the case of the opioid example, you will be visiting people who have read the new CDC guidelines from last week cover to cover. And you will be also visiting people who don't even know that the CDC revised its guidelines this month. And you need to understand, as you talk with them, which category of knowledge are they in? And as we've heard and will hear from all the opioid-related presentations at the meeting, but also this applies to other conditions as well. But in some ways, opioids are kind of a poster child for this. You will also need to understand where are the doctors and other prescribers that you talk to coming from. Are they people who are keen to know that they now have more access to buprenorphine because of important policy changes that were made last year that they may not actually have heard about, and want to learn the sometimes a little complicated way of getting somebody started on buprenorphine? Or are they people who are of the belief that, these people who take opioids too much really need more willpower, and if they only could clean up their act, there wouldn't be a problem? Or are they people who are saying, I don't want to learn how to prescribe buprenorphine because I don't want a lot of junkies in my waiting room? Forgive the phrase, but you'll hear it. And, if you don't know that, and if you just go in with a kind of prepared script of here is what you need to know about opioids in the end of 2022, you're going to miss all that, and you won't be able, and again, you know this already, but I'm just repeating the obvious, you won't be able to respond to, is this person a person who has never heard of the guidelines? or a person who really doesn't like to treat people with substance use disorder, or a person who is aware that this is a health care crisis and they want to learn how to deal with it better. And again, it's the talking to them back and forth that many of you have learned through NaRCAD and other related programs how to do so well. And if you don't do that, and we still see this a lot in the field, if you just basically, in effect, say, sit still for 15 minutes so I can do a lecture at you, you're not going to have the chance to target your presentation, whether it's about opioids or diabetes or infectious disease or anything else for that matter. And again, you can't just put this in a memo and send it to people, nor can you, sort of the modern equivalent of just sending somebody an email is have a drop-down menu and sort of tell them what to do, because that just, as we know, can be useful for some things, but is not going to change complex behavior in the most effective way. Next slide, please. Okay, different kinds of toxicity. Again, trying to keep things as current as possible. In the Times last week, there was an article about 70 children in Africa who died after they took a contaminated medicine that was made in India. And the health minister in the affected country said the problem was the result of really two things: loose regulation of production in the exporting countries, combined with a lack of quality assurance processes in their recipient nations, which he said was a dangerous cocktail. And I thought of that in some ways, not that we're interested in cough medicine in Africa, but in a way, the same can be said about the transmission of information. That we've got problems throughout the healthcare system, certainly in the US, with difficulty in ensuring the production, not of cough medicine, but of information on the starting end in the US. And that is something we can lay at the doorstep of both FDA and the manufacturers, which don't always do a great job of producing the information, but also on the receiver end, the toxicity among the users of that information. That is, we don't have great safeguards in a kind of public health information sense to make sure that even if crappy information is being produced, are the receivers of that information empowered to know that it's not such great information. And while we can't, in this conference, fix up the FDA and the industry, we can certainly operate on the other end of that information pathway about trying to make sure that people, if they are presented with toxic or potentially dangerous information, will, in a sense, have some immunity to it and will be able to not get into trouble with it. And the irony here is that a very related chemical was the result of a scandal in 1938 in the US, where there was an elixir that was taken by many, many children, 100 of whom died as a result of its poisoning. The good news here is that that is what led to the nation deciding that FDA needs to be able to have some control over the safety of the production of medicines. Next slide, please. Okay, so you've heard this in the last few minutes. The tainted medicines are a little bit like tainted drug information. We have problems on the production side and problems on the consumption side. And I take comfort in the fact that we did, at least initially, although we may be backsliding a bit, take a position in the US to make sure that toxic products are not being produced by the industry. And we are now very slowly groping our way toward trying to make sure that non-healthy information is also not being disseminated. The silver lining is that we were able to get on top of that, and hopefully we'll be able to treat dangerous information the same way we've treated dangerous drugs over the years. Next. And by the way, dangerous, I should also include drugs which are ineffective or inert or heavily hyped, but not actually useful for anything. That was, for you historian buffs, what gave us the FDA in the first place in 1906, where there was a lot of crap being sold out there that actually didn't do much of anything. It was sort of flavored and colored syrups. And so the early step was to say, let's not have stuff out there being sold as drugs that doesn't work because it doesn't have anything useful. Then in 38, we got to the rule that it can't kill you. And only in 1962 did we eventually get to the point where, and there has to be good evidence that it is actually effective. And we are worried that we may be backsliding on that requirement a bit, but That's again work we do in the portal division of the pharmacoepi division, not necessarily anything we can fix through academic detailing, except that we can help people know about the limits. And I can mention that briefly in wrapping up, that when Aduhelm came out, aducanumab, the virtually totally ineffective drug for Alzheimer's, the summer of before last in mid 2021, we did ramp up to produce an academic detailing program that was funded by a foundation in order to enable us to teach doctors, with the assumption that Aduhelm was going to hit the market in the summer and fall of 2021, how to, in a sense, resist the very heavy marketing campaign for it that its manufacturer planned. Luckily, a lot of healthcare institutions and payors, and ultimately the Medicare program itself, stepped up and said, this is not something that ought to be used, and the drug died a quiet death. But I mention that for two reasons. One is that we were actually approached by a foundation that said, you're going to need to start an academic detailing program about Aduhelm. But in addition, there was a way of trying to get ahead of the curve. And I mention that because we're going to be seeing some more supposed amyloid active drugs for Alzheimer's coming out in literally the coming weeks. And we are now resuscitating that attempt to do sort of proactive academic detailing to try and help doctors and their patients and other healthcare professionals combat the onslaught of marketing of this new blockbuster set of drugs, and there's more than one, that will reduce amyloid levels and may or may not have a really meaningful effect on patients' cognition. So it is something in terms of academic detailing interventions, we can not just mop up bad prescribing, but we can try to get out ahead of the curve. And as soon as we've got anything pulled together, we'll be happy to put it up on the NaRCAD website so any of you can take advantage of it as we finish developing it, because it was estimated that with Aduhelm, had it been used to the full extent that it was expected to be, the federal expenditure for it would have been about the same as the annual budget for NASA. And so I don't know whether we're going to be seeing the same thing with these new drugs. But again, I know that all of us can think of better things to do with billions of healthcare dollars, particularly for older patients. So to wrap up, next time somebody asks you, why are you doing this? Why aren't you out, taking care of patients or discovering new drugs or doing science or something? I think you can point to the COVID example as an instance in which we really were able to see in kind of both bad and good ways how communication of information literally was a matter of life and death. And to remember that even though it's not on the headlines every day, that is still the case for the management of an awful lot of other chronic illnesses and other conditions that we see every day. And if they don't believe you, you can give them some cough syrup. Okay, I think that is my last slide, and we have a moment or two for questions or comment, and I will leave it to Bevan to maybe call on people for a few moments of discussion, and not just thank you for your attention, but thank you really from the bottom of my heart for all of the great work that all of you are doing around the country and around the world in moving this academic detailing movement forward. Thanks.
Thank you, Jerry. Much appreciation, and looking forward to seeing the chat box fill up. I know we already have a couple questions. I, at the risk of seeming like I'm playing favorites, am going to turn it to Mike to kick us off. Mike, let's unmute you. I know you have a question up your sleeve.
Yeah, thanks, Jerry. That was engaging and insightful as always. I want to let me draw a couple of lines around the question or the topic I'm really curious to ask you to reflect on. You pointed out how the COVID example is distinctive and yet has historical echoes in a lot of different ways. One of the things that I'm struck with in terms of COVID, I take your points about the challenges that clinicians have in reading the literature when you're dealing with some of the new data about things like diabetes, heart failure. For a lot of the COVID vaccine literature, if we put aside the relatively modest number of clinicians, physicians and others who've really gone all in for sort of misinformation, for most clinicians, they know the vaccines work, they sort of know the data. but they're struggling with tools to deal with the sort of deep vaccine resistance, vaccine hesitancy. It almost reminded me of some of your very first, I think maybe it was in the first academic detailing study, where you talked to clinicians and you were doing antibiotics, and you talked to clinicians who said, I know antibiotics don't fix viruses, but the patients don't believe me, and I just got to get through my day. And you're sort of trying to figure out ways to go with that. And I can see the same kind of thing with a busy primary care doctor. I know the vaccines are important. I know we need to do it, but the patients don't believe me. And if I spend 40 minutes arguing with every patient about it, who's, vaccine hesitant or whatever, I'm not going to get to talk to them about their mammogram or their cholesterol or whatever. So how are you thinking about the ways that we in a community can get clinicians the tools they need to combat misinformation? Because part of what you're talking about interpreting the literature is making sure that we as clinicians don't convey wrong information. But some of it is, how do we have the tools to bring patients around, which is something I think you were grappling with 40 years ago, but I'm not sure as a field, we still really know how to do it.
Thanks, Mike. That is a great point. And it's an interesting coincidence that that was also an infectious disease related example. And the way we learn to do that may be instructive in relation to all the other academic detailing programs that are represented at the conference. And that is, we learn from drug companies that the way they formulate their marketing campaigns is that they begin with focus groups. And that's something we try to do at ALOSA as well, where you gather together a bunch of docs who are in the population that you're trying to educate. And you ask them, so how do you make a decision about X, whether it's a drug for diabetes or hypertension or an antibiotic or talking to patients about vaccination? And you learn from them what it looks like to them on the front lines. And that's where I first had the kind of aha insight that a lot of doctors who were overusing antibiotics, again, this was in the 80s, so I guess I'm allowed to have been a little naive, were not doing it because of ignorance, but because of the fact that they just wanted to deal with patients quickly with a busy waiting room, and they figured it wasn't going to hurt that much, and the patients will get mad if they don't do it. So they would write a prescription for an antibiotic for a viral upper respiratory infection. And what that taught us to do is to provide them, and in fact, they suggested it, if you could give me something I can give to the patient to explain in lay language why it is that they don't need an antibiotic and are actually better off without it, that would make it much easier to A, give them something, namely an unprescription, and B, feel like I'm satisfying their needs without giving an antibiotic. So we put together, as some of you know, what I think of as the first direct-to-consumer unadvertisements, where the doctor had something written for patients and he could say, okay, here's why you're better off with an antibiotic. Here's what you can do for fever, for aches, for congestion, check boxes, write the patient's name on the top, write your name on the bottom, and they feel like they've gotten something from the doctor. In the case of COVID, I've not seen very much of reaching out to doctors to engage their patients. Of course, everything was so chaotic during the middle of the pandemic. People just wanted to sort of get through the week, but a way of helping, because now we still have that need. There's been a remarkable non-uptake, as you know, of the latest bivalent vaccines. So something that an academic detailing program could offer to a doctor, not to teach them about the vaccines necessarily, but for them to give their patients who are resistant, so that it's not a matter of, hey, you do your thing and let me know how it comes out, but to really have the doctor be an agent of prescribing encouragement for the vaccine or for Paxlovid or any number of other issues around COVID.
Thank you, Jerry. We do have a couple more questions, and I'm going to try to squeeze in as many as we can. One question that came at the beginning of the wrap up here was from Elizabeth Fallimach of Maine. What's the best advice to respond to a prescriber who may have latched onto parts of the recommendations, but maybe not parts of others? I don't know if that's something that you would have sort of a distilled nugget of advice around.
Now, are we talking about the opioid recommendations from the CDC?
Yes, Elizabeth has indicated, what if someone thinks don't taper patients at all versus don't taper patients rapidly? Elizabeth, can we unmute you just to kind of get more of a sense of exactly what you mean by your question? That would be lovely.
Yes, interestingly, we recently had a prescriber who drew the attention of the DEA and was a really strong advocate of not tapering patients forcefully without buy-in, because of the risks associated with that. And yet in doing so had a panel that drew the attention of the DEA.
Great question. Hi, Liz. Good to see you. We always appreciate all your input, in particular on opioids and your help at ALOSA and NaRCAD. Yeah, great question. I think the thing to do, as in a lot of relationships, whether it's with a doctor you're trying to educate or even a doctor with a patient, is to try to solidify the areas where there is some agreement and build on that. And probably acknowledge the fact that, yeah, it does now look in retrospect as if perhaps the CDC was a little too vigilant about recommending tapering, and maybe that very firm position was not ideal. There was a good paper earlier this year by Dr. Coffin in the New England Journal that many of you will have seen on that topic. So to kind of embrace the agreement that you might have with the doc, and then to kind of explore, okay, given that we can agree that cold turkey is not a great clinical response and that people can get sick from it, what are, let's talk together about what kinds of people might benefit from a slow, gentle taper, rather than saying, in effect, we agree with it, the tapering sucks, because that's kind of the end of the discussion. And so solidify the agreement and then try to edge into the idea that that maybe one can go a little bit further. And, as we all know, going a little further is often better than going nowhere.
That's true in all walks of life, I think. Thank you, Jerry. We have another question here from Jonathan. Thanks for throwing this our way. How do we really differentiate our information from other types of information, beyond this is evidence-based? Because there may be other folks who say they have evidence-based information. So what's the way that you would distill kind of, from a detailer's perspective and for credibility coming in and really being able to sell, like, this is sort of the best evidence, what kind of backup would you?
Boy, that is a great question. And yeah, I think it comes up not only in the first visit, but probably in one way or another in every visit, to really emphasize what our kind of stock and trade is in academic detailing. There are zero commercial influences, I trust, in all of your programs. So it's not like this, because often people are saying, well, you're really from Pfizer, right? And, to explain to them that nobody's making any money off of any of our recommendations. And also to say that the materials are put together by teams of docs and pharmacists and others who spend a lot of time and energy going over all the evidence and distilling it to make it as useful to the end user as possible, and to kind of share with them all the machinations that I know we go through at ALOSA and that many of your programs do. I know the VA does that as well, and Kaiser. And all of your programs, so let them know the absence of commercial influence and the fact that that this is really a distillation and that they can benefit from all the very intense work that's been done by a team of smart people to come up with recommendations only with an eye toward what's best for your patients. And that ought to count for something, especially when they think of all the other sources that they could choose from as an alternative.
Thank you, Jerry. We have just a few more minutes. I want to focus on this question from Lauren Rigier. Excuse me. So he says, knowing that evidence and guidelines will, inevitably change, how should that affect the delivery of AD? How do we make a compelling case for a specific key message when we know limitations around its understanding and context could result in unintended consequences?
Good point. Hey, Lauren, and thanks for all the great work you've been doing in Canada and elsewhere over the years. This is something which I've thought about again during COVID, which kind of put so many things into relief so clearly, that people would say, well, you can't believe the government because first they said you only needed, 1 or 2 shots. Now they're talking about boosters, or, first they said this and then they said that. And so why do I believe any of it? And I think that relates to Lauren's question. In a lot of ways, this is about what I've come to understand is a fundamental disagreement about how medicine works and how science works. That the essence of medicine and science and evidence, as you all know so well, is that it changes over time. And it may be something that you might have told your doctor a year or 2 ago. I mean, the diabetes drugs are a great recent example of that. That no, you don't start everybody on metformin. There's other ways of thinking about it. And in a way, it's kind of the meta education. You've got to help docs understand that just because the evidence base changes and suggests a new approach doesn't mean that, they were being deceived or that it's all worthless or that where does this stuff come from, but that what a lot of people spend a lot of time doing every day is refining the evidence base and making it better and better. And the whole essence of science is that we learn, and things we thought were true turn out not to be, and we discover new things. And that's why, we are not still using leeches and bleeding and cathartics to treat things. And that's part of your role in bringing things to doctors and other healthcare professionals, that things change. That's good. It's not evidence that science doesn't work. It's evidence that science does work. And it's stressful for the end user. And that's what you're there to help them with.
Excellent. Thank you, Jerry. We have 2 questions left, and I am going to, this is sort of the opposite of working nepotism. Paul Finicos from Alosa, I'm going to ask you and Jerry to have a sideline chat since you get to connect often. But those of you who have seen that question and are interested in it, please chat in the chat box about ways to get health systems more interested more interested in underprescribing and long-term value around anticoagulation, heart failure, et cetera, to encourage a wider spread of AD. So please feel free to sound off with each other. And I know Paul and Jerry will get together. We have a final question, and then we're going to wrap up from Jackie Travers in Oklahoma. She says, warning, wordy question ahead. We struggle with the same lack of preparedness in our current pharmacy students. When they arrive ready for their 4th-year rotations, they are missing the most basic journal evaluation skills. Even looking at disclosures is not on their collective radar. Granted, most clinicians will not have time to evaluate many journal articles once they're in practice, but that being said, how can we work towards embedding these skills into the curriculum at the speed that we embedded the 6th vital sign?
Yeah, right, which maybe we want to unembed a little bit now. That is a great point. Boy, it's hard enough to change the practice of clinicians. They say that changing a medical school curriculum is like moving a graveyard. And that certainly has been my experience, that I don't know is the quick answer, but I think we just need to keep reminding our colleagues, whether it's in schools of medicine or nursing or pharmacy, that if they only can do one thing for their students, they should teach them how to think about evidence, because like I said, everything else will change, but how to think about evidence is got to be one of the most important skills. And I don't know, I can't claim that we've gotten there. Our course at Harvard is an elective that was taken by about 30 students, and God only knows what happened to all the other students that are not able to take that. But it's clearly the future. We got to get this right. And Paul, by the way, I did not talk to Paul about his question, but the one thing I got to say is that if Mr. Fetterman loses his election in Pennsylvania, it'll become a great case study on the underuse of anticoagulants in atrial fibrillation, because apparently that's how he had his stroke. And if only he or his doctor, I think his doctor tried and he didn't cooperate, had been prescribing him whatever anticoagulant of choice was the one that he might have taken for his AF, perhaps he'd actually be able to be a little more coherent on the campaign trail. So yes, it matters.
All right. And thanks, Christy, for talking about Tom Brady always works here in Boston and beyond, around the ways in which evidence increases and clinical practice changes along with the evidence. All right. So thank you, Jerry. We appreciate you very much. Those of you who have more questions for Jerry, send them on over to Anshul or narcad@bmc.org, and we will triage them to him. Many thanks, Jerry, for your annual AD talk. Up next, we have broadening our scope using unique applications of academic detailing. And who better to start off with than our friends over in Norway, with whom we've been working probably as long as this conference series trajectory. So Anna, please kick off with introducing COOP.
Yes, and thank you again, Jerry, for kicking us off today. I am pleased to introduce our first field presentation speaker, who is again joining us from COOP, which is the Norwegian Academic Detailing Program. And as Bevan mentioned, we have worked with COOP for over a decade, and we are excited to have Ingrid Steen with us today, the director of COOP. And Ingrid has been working with COOP since 2018. She started as an academic detailer in 2019. She is involved in both program and materials development and design, training new academic detailers, coordinating scheduling, and conducting detailing visits and program evaluation. Ingrid, it's my pleasure to hand the mic over to you to share about one of COOP's recent campaigns, the better use of menopausal hormone therapy. Ingrid, welcome.
Thanks for the introduction and for the possibility to talk here today. As you said, I'm Ingrid. For those of you who know Harold, I'm the new Harold. I'm the director of COOP, and besides COOP, I work 50% as a drug consultant at the RELIS, which is the Regional Drug Information Center in Norway. But today I will talk to you about our campaign Better Use of Menopausal Hormone Therapy, MHT. I have no financial disclosure or conflicts of interest. The main focus of my speak will be about the campaign Better Use of Menopausal Hormone Therapy, and I will take you through the background for the campaign, key messages, results, and some future plans. But in case some of you don't know so much about COOP, I will just briefly say some words about COOP in general first. Next slide. COOP is an abbreviation for Kunnskapsbaserte oppdateringsvisitter, which is the Norwegian academic detailing program. It's run by RELIS and the Department of Clinical Pharmacology in 4 cities in Norway. And as you said, COOP started in 2015, and since 2018, we have been founded by the Norwegian government to develop and deliver academic detailing campaigns to physicians in general practice. And here you can see an overview of the 6 COOP campaigns, starting with the NSAID campaign in 2015, and up to the campaign starting just now in September, Better Use of Drugs Against Migraine. And as you can see, there has been a slight increase in the numbers of GPs visited, but we are still far from reaching out to all the approximately 5,000 GPs in Norway. Next slide, please. We are represented in different medias. We have our own webpage. One forward. Legemidler.no. We are referred to at NEL, corresponding to Medibas in Sweden. It's not exactly up to date, but maybe in a small scale and Norwegian oriented. We are on Twitter, Instagram, Facebook, and we publish in different papers. And we profile ourselves to increase the knowledge about the campaigns and to highlight the need for us, for the founders, and also to easier get access to doctors and maybe also get the GPs to book visits themselves through our online booking form. As I said, we make calls, send emails, and even sometimes letters to book visits, but we also try to make the GPs contact us and book a visit through the online booking form, where they can book both digital and in-person visits. Through this QR code, you get straight to the booking form, as you can see on the right side.
All right, and Anshul has dropped that booking form just so you can check it out in the chat box. So here is one of our polls for Ingrid's presentation. How do you schedule visits? Do you use an online form, email, phone call? Many of you have talked yesterday about specific programs. So go on over to your poll everywhere, or if you're not as comfy with that, you can drop it right in the chat box. All right, so we're seeing phone calls, SurveyMonkey. That's interesting. Great. I know folks use that, or Google Forms sometimes. Via email or in person or email, which is terrific. Getting back to cold calling, online forms, email, phone, and text. That's interesting as well. A lot more for things like phone and email, can keep them coming. But it seems like all the ones we have here are just sort of a diverse approach to connecting. Fax, we remember from yesterday, fax is not the dinosaur we thought that it was. And if there are any specific programs, I know yesterday Calendly was mentioned, and twist of the arm. Yes, applying that pressure. We have MS bookings as an opportunity here. And we at NaRCAD do have on our virtual e-detailing toolkit a selection of different programs. Nicole from CEP is saying time tap. that's a new one. So we'll go ahead and move on. And thank you, Ingrid, for asking this poll.
Mhm. So over to the topic I was supposed to talk about today, menopausal hormone therapy. The subject of this fifth CUP campaign was chosen based on suggestions from GPs and on dialogue with the Norwegian Association of General Practitioners. And due to uncertainty among the GPs regarding what is the best practice for MHD. And this is due to the discrepancies and changes in therapy recommendations from the big American studies from around 2000 and until now. Next slide. And the purpose of the campaign was to give the GPs updated knowledge about the pros and cons of hormone treatment during menopause, to increase the quality of information women get from the GPs during menopause, and to give the individual woman and GPs a better foundation to make decisions about treatments. We started booking in August, September 2021, and we planned for both digital and in-person visits. There were no planned quantitative measures for this program, since there was no goal of general higher or lower prescribing of one of the other MHT preparations. But we sent out evaluations form to all the participants within 1 week after the visits. We have built up a lot of experience during the 5 campaigns, and I might speak for myself, but I think the brochures has become better and better for each one of them. It's not going to be perfect the first time, so. And the brochures from all our previous campaigns are published on the webpage. And the material consists of a 4-page brochure with an insert, most often with tables. And it's designed to be an impactful detailing aid during the visit, but also after the visit for the GPs. So here on the right side, you can see the brochure from the MHT campaign. And at the top, we have a figure that says something about the background for the campaign, balancing between the pros and cons or benefits and risks. And the key measures are presented. And the key messages are repeated with further information and graphics as we go through the brochure. On the last page of the brochure, we offer options for continued contact for clinicians to ask follow-up questions or schedule for a new meeting. And here you can, or the QR code is presented here at the end page on the new brochure. You also see the insert with tables for drugs, different drug preparations for the MHT. So next slide, please. Here you see the 4 key messages for MHT campaign, and I will present these to you and take you through some of the evidence-based information within each key message really briefly today, because I just have 15 minutes. Next slide, please. MHT is the most effective treatment for vasomotor symptoms. However, the treatment benefit must be balanced against the future risk of adverse events. Hot flashes and night sweats are often considered the cardinal symptoms of menopause, and 1/3 of the Norwegian women reported daily troublesome hot flashes during menopause. And MHT reduced the frequency with 75% and the intensity with 87%. So it is an effective treatment. But on the other hand, MHT increased the risk of breast cancer, but it depends on the duration of treatment and also the regimen used. So it's balancing between the risk and the benefits. Next slide, please. Here you can see a dot plot of the 20-year breast cancer incidence per 50 women who have used estrogen plus daily progesterone for 5 years versus 50 treatment-naive women. And as you can see, cases of breast cancer expected in women without MHT are 3 over 50, and you have 1 additional case of breast cancer in the women with MHT for 5 years. Additional cases of breast cancer expected in women treated with estrogen plus intermittent progesterone is 1 over 70, and additional cases of breast cancer expected in women with estrogen only is 1 over 200. So it seems like it is the progesterone that is the or driving the risk for breast cancer. On this graph, you can see that the breast cancer incidence increased with increasing age and also with the duration of treatment. So you can see the graph on the top is 10 years use. The in between is 5 years use, and the lowest graph is no MHT use. In the absence of contraindications, the risk-benefit favors MHT for most women if treatment starts in conjunction with menopause. We go through this flow chart vertically downwards with the GPs. We assess indication, contraindications, and risk factors. You can press at least one forward. So if there are an indication, you should go further on to assess contraindications. And if there are no contraindications, you can assess the risk factors. And if there are low risk, you can choose between the treatment options. But on the other hand, if there are no indication of use, you shouldn't use menopausal hormone therapy. And if there are contraindications present, you should avoid systemic therapy or systemic hormone therapy. And if the patient has a high risk of developing, for example, breast cancer, you should or preferably no hormonal treatment. Next slide, please. But let's go back to the cases where there are an indication, there are no contraindications, and the patient has low risk. Then use of MHT, estrogen plus progesterone for most of the women are indicated. But as there are a whole lot of different possibilities and choices when it comes to choosing the right preparation, the treatment should be individualized. Next slide, please. As I said, the detailing aid also consists of an insert, and here you can see the included table of different preparations, including administration form, active ingredient, and dose. So it's an overview of the marketing preparations in Norway. Key message number 3 is that women with early menopause should be offered MHT until the expected age of menopause, provided there are no contraindications, since early estrogen deficiency is associated with an increased risk of negative health effects. There might be different causes, but the symptoms are more or less the same, and the treatment options are MHT and contraceptives, or SSRI, SNRI for those where MHT are contraindicated. Next slide, please. Key message number 4, treat with minimum effective dose for the shortest possible time. As for most treatment, 3 months after MHT start, the chosen regimen should be assessed regarding effect and side effects. And the additional risk of breast cancer significantly increases with treatment lasts over 5 years and increases further with longer treatment. The GPs should offer medical checkups at 1 to 2 years intervals to assess the benefits and risk of continued treatment. And regularly consider changing treatment or withdrawal. Relapse may occur about 2 weeks after discontinuation, and you should wait at least 2 to 4 weeks before considering restart of treatment. So you have to balance between risk and benefits all the time. Over to the results. Since September 2021, we have visited, actually it is 1,310 GPs with the AD program better use of MHT. And we have sent out approximately 1,200 evaluation forms, and the response rate was over 50%. And 99% answered CUP is a good way to get individualized, up-to-date evidence-based drug information and are likely to accept new visits. Next slide, please. One of the questions we ask are, to what extent will this CUP visit change your practice within the current therapy area? And the current therapy area in this case is MHT. And as you can see here on the graph, 27% answer to a great extent and 62% to some extent. And one forward, this is in concordance with previously campaigns. Next slide. We send out the evaluation forms to get some feedback on a specific campaign, but also on the CUP method. And through 4 previous campaigns, Coop has documented a high degree of satisfaction and credibility among GPs. And this is for all the campaign, but the orange one is for the MHT campaign. And as you can see, 90% of the GPs assess Coop as a suitable method for relevant evidence-based drug information. And over 95% are well likely to accept an offer of a Coop visit for another campaign. And as you can see, the results from previous campaigns are much the same. So to conclude, it is possible to create a successful intervention program that does not have higher or lower prescribing rates as a goal. And to reach out to the GPs with up-to-date evidence-based drug information is a goal itself. And 90% of the GPs will change their prescribing practice after the visit with the MHT campaign. So what's up next for CUP? As I said, we have already started a new campaign, better use of drugs against migraine. So we will continue with this one. And we will look closer into possible benefits of digital visits. And we will work further with profiling. And as the first CUP campaign in Norway documented a reduction in the prescription of diclofenac by 16 to 18% in intervention municipalities compared to the rest of Norway. And there are ongoing studies regarding both the anti-diabetic and the opioid campaign, and we hope to soon be publishing. The last one is, I'm not so happy about that one, but there will be some changes in the organization coming up in 2023. So
All right.
That's it from me.
Thank you, Ingrid. That's wonderful and so much compelling data. I want to make sure you have plenty of time to answer some questions. Thank you so much for sharing. And, the first question is very much about the difference between what's happening in Europe and in Norway with here. So please feel free to share what you're aware of. But we have a question about whether the clinical recommendations in Europe may be different than the US and why we think so. Is there a focus on different evidence? And the thought behind that, Ingrid, is that here in the US, HRT and MHT are recommended less often, or at least that's the thinking. Do you have any reflections on that?
Or less often now than before, or?
Yeah, I believe so. And those of you who know more about that, perhaps Jerry or Mike or other clinicians, the idea that, it's been sort of out of favor a bit more over time here. Jerry, is that something that you might be able to talk a little more about, just in terms of any research you've read? Or Mike, I know that,
I can say in Norway, there was a big reduction in the prescribing after 2000. I think it was 170,000 women who used MHT in 2000, and in 2014 it was only 50,000, if I remember right. But new studies and reanalysis of the big Women Health Initiative and her studies from 2000 has shown that if you treat, as I said, in conjunction with menopause and keep the duration of treatment to the shortest possible time, the risk for the patient under 60, you have at least to do the risk benefits, but it doesn't seem that the risk for those patients are that high that was published back in 2000. So,
yeah, Mike may be closer to this than I. My impression is that the key words there are short-term use, that it's at its best for symptomatic relief used for a brief period of time. And the idea of putting women on it at menopause and keeping them on it forever is the use that I think is really discouraged now. Mike, does that make sense to you?
Yeah, I mean, as Ingrid says, the pendulum has really swung. I mean, you captured that beautifully. And just by the way, kudos, congratulations on a terrific presentation, and the reach of your program, over 1,300 visits, and the engagement that you have to get all those surveys back is just such a rich source of information. And what I'm struck by is that as you got at, it's become a much more complicated decision. There was sort of, everybody was using it, as Jerry said, and then everybody moved away from it. And now it's kind of in some situations for some period of time. So what I'm interested in is sort of related to the question I asked Jerry at the end of his talk, because it's a risk benefit decision, as you said, you're doing a topic where you're not making a specific recommendation to the clinicians you detail to say, do more of this or do less of that. You're telling them to communicate a risk benefit decision to the patients. So I'd be interested in your reflections on how do you, when your message is spend more time with the patients discussing this, was that challenging? Because I'm sure physicians are busy everywhere. And did you have to, how important are there accompanying patient materials if you did that, if you're sort of setting people up for a discussion with the patients?
We use as the dot plot I show you is from a Lancet article from 2019, and most of the doctors think this dot plot is quite illustrative for the patient as well. So I think they use that one. And when we go through the list of different MHT preparation, there's someone, even though we don't have one recommended drug in Norway, we can show them some of them who has the least risk for breast cancer. If you have, in Norway, it's very common to have the progestagen intrauterine device, who has less breast cancer risk than other preparations. So, but we use a lot of time on the key message number 1 and to talk about how to communicate risk. Because for some women, 1 over 50 is a lot, and for other 1 over 50 is not a lot at all. So.
Thank you, Ingrid. We so appreciate you sharing, and it's so great for us to understand what's happening from a global perspective. So thank you for representing Norway. We love to have you, your whole team here every year, and you're keeping that streak going for us. And so many thanks. If anyone has other questions for Ingrid, thank you. Please pop them in the chat and we'll triage them to her. All right, Anna, let's introduce field presenter numero dos.
Yes, and thank you, Ingrid, for that lovely presentation. We are going to jump on our AD bus and head to Wisconsin. With pleasure, I'd like to introduce our next speaker, Nicole Green, the Director of Ambulatory Pharmacy Service Program at ThedaCare. Nicole leads the comprehensive strategic plan to embed pharmacists within family and internal medicine clinics as providers and vital members of the primary care clinical team. Her program utilizes AD as a means of building professional relationships, establishing credibility, and influencing prescribing improvements. Nicole, without further ado, I will hand the mic to you to speak about your team of all pharmacist detailers and how you've been integrating pharmacists into primary care. Nicole, hello and welcome.
Thank you. I'm honored to be here. I have no disclosures to share, and I can't get started without recognizing that I am a Saskatchewan born and raised and educated pharmacist. So I want to give a shout out to all my Saskatchewan peeps on the call, and so excited to be here. Who knew you'd see somebody from Saskatchewan with Wisconsin attached to their name? All right, so let's get started. ThedaCare, I'm representing ThedaCare. Who we are an integrated health system located in northeastern Wisconsin. We have 8 hospitals. A brand new hospital just opened up here. You'll see the picture, our orthopedic spine and pain center, 39 primary care clinics, 2 skilled nursing facilities. We have a hospice and home health, and we are an ACO with 140,000 plus lives attributed. Our mission is to improve the health and well-being of our communities by empowering each person to live their unique best life. Our vision is we will reinvent healthcare. What a bold vision, right? Reinvent healthcare by becoming a proactive partner in health, enriching the lives of all and creating value in everything that we do. Our promises are, I promise to be a proactive partner in health by putting patients and families first, making healthcare easier. That is a big one too, and delivering high quality, affordable care. When we talk about ambulatory pharmacy programs, what I've really learned early on is that an ambulatory pharmacy program is not the same as an ambulatory pharmacy program is not the same as an ambulatory pharmacy program. What in the world do I mean? I mean that when I try to reach out to other organizations or programs with an ambulatory pharmacy program, that often looks very different, makes benchmarking a challenge, makes conversations a challenge. So my key point is understand your program, your role, and your patient population. So here is ours. We are pharmacists embedded in family medicine and internal medicine clinics who serve as pharmacist providers, who see patients for scheduled appointments and are very busy with our appointments every day. We are credentialed in that role as well. We serve as medication experts, as a resource for the full clinic team. We are absolutely partners in complex patient care management and patients who are simply not meeting their medication-related goals. And we serve as educators through both formal presentations and, of course, academic detailing visits. My challenge to anyone considering a program is to first determine your why. My goodness, I'm just reading a book, Simon Sinek, I believe, Determining Your Why. And I didn't realize I was just doing this until right now as I'm presenting the slide. We determined our why. So what is your why? Here's our why. You can see the graphic on the left. Wisconsin suspected opioid overdoses by month. We've talked about the pandemic today, and this relates to that as well. I want you to look to that middle blue bar in 2020. What happened in May? The opioid overdoses nearly doubled. And that stayed elevated through end of 2020, and it got worse and worse and worse. And if I were to show you the graph for 2022, it would not look a lot better. But this tells you the impact of a COVID pandemic on something seemingly unrelated, opioid overdoses. You might also do so, create an ambulatory pharmacy program because you're trying to correct the spend and the waste associated with medications. You might implement a program to assist your peers, your physicians, your providers in burnout. Having a partner in complex medication management has a positive impact on reducing burnout.
All right, we got a poll here, everyone. If you want to grab your phones or go to the chat, what value does a pharmacist add to a family medicine clinic? And I know the pharmacists in the audience are ready to be like, can I do more than one word? All right, here we go. Kicking it off, we have expertise. Yes, of course. All of the value. Tell us what else. What would we be missing without a pharmacist at a family medicine clinic? And whatever that is, flip it. Medication expertise, everything. You're getting a lot of everythings here, Nicole. What else? Yes, knowledge. Any other thoughts? Medication expertise, of course. So these seem to be, are these things that immediate consultation? Nicole, are any of these things surprising to you?
No, I'm smiling at the everything comments.
Yeah,
though.
a ton of value. Coordinated care, we love that. So we're getting a great sense here. And then over in the chat box from Mary, we have opportunity for education. So seeing lots of expertise, education, coordination, and connection here. All right. So if you have any more things to sound off on, please move to the chat box and we will move over to the next slide. Nicole.
So what a fantastic segue to my next thing, particularly with the everything piece. So when we talk about our key performance indicators from our program, that is a challenge because I don't have a singular value that I use for my KPIs or my return on investment. It really speaks to that whole everything piece. So these are some things that you might consider. Quality performance indicators. In other words, changes in prescribing practice. What a great metric related to academic detailing, right? Here's what we are trying to drive. Here's what we are trying to influence. What impact am I making in that? We can measure just simply the number of academic detailing visits that are accepted and the response rate with those as well. For my program, since we are providers as well, we also look at volume metrics, so accepted appointments, and you can also identify particular target patient populations. We can look at referrals, appointments, and patient panels, mirroring those of our colleagues, but understanding the differences in doing so as well. We do look at revenue. We do have the ability to generate some revenue, of course, to support our program. And ACO, or accountable care organization payer performance. So if you're not familiar, you might be part of an ACO where you have agreements with various payers. And if you do better in certain pharmacy related measures, we focus on medication adherence as well as statin gaps. This translates to earnings for your organization, so it can help you to create your program as well. We are dedicated to a principle of practice called comprehensive medication management, or CMM. It is our standard of practice. It is a distinguishing feature of our service. And important to note in benchmarking, I say that because it's very different than a program that focuses, for example, only on INR management, not to discount that, but when you're looking at the entire picture, that's going to consume a lot more time than an anticoagulation visit. So the definition really here is ongoing accountability to the care of the whole patient. Two key components, the whole patient and that ongoing nature. I don't fix you and then discharge you. It makes us unique amongst the clinician care teams, provides a service that others are unable or unwilling to do. You might utilize this principle as a way to justify the decision to place a pharmacist as the clinician in the particular program. And there is a growing list of literature to support the impact of programs that follow this principle. Our purposes with academic detail, and everybody has their own unique spin, ours are certainly to drive improvements in prescribing practices, and we always build a metric that relates specifically to that initiative. Admittedly, we utilize academic detailing to build and establish our professional and collaborative relationships with our providers. We are 1.5 years into our program, and certainly this was really important at the beginning to get that one-on-one time with our clinicians. Obviously, use it to discuss patient scenarios, bringing forward that individualized aspect of it, identifying patients for partnership, and we can use this as a way to align with our organizational priorities. I want to share some of our materials with you. So our first initiative was related to opioid stewardship. This shows the opioid epidemic in Wisconsin. This is actually a beautiful folder material that was co-branded with the PSW, Pharmacy Society of Wisconsin, a fantastic organization that has really helped us to move some of these initiatives along. This is specific to our ThedaCare market area. We are in a smaller area of Wisconsin, not in Milwaukee, for example, and we didn't want people to say, well, that's a Milwaukee problem, that's not our problem. So this is personalized to our market area. This is a little bit about how naloxone can help, talks about the products available, talks about the algorithms for naloxone co-prescribing, utilizing opioid dose as your guidance on whether or not they need it. Recognizing as well, though, on that bottom half of the screen, that the risk of overdoses increases with other factors, not just related to morphine equivalent daily dose, as you all know. Next slide. This is tips on how to discuss naloxone with patients, how to prescribe naloxone to your patients, and you could see at the bottom that this, again, was co-branded with our organization and PSW. The second academic detailing key message related to opioids, the use of opioids along with benzodiazepines. We all know this, right? The increased risk of death from overdose when you use these two medications together. So providing some data on this specific initiative and this specific message with a visual graphic on opioid involvement in benzodiazepine overdoses. The next message was on monitoring opioids. In other words, what we were trying to achieve with this one was, let's not put patients on opioids and then forget about it. Let's routinely evaluate. Are they benefiting? Are they still benefiting? Can we look at a trial of decreasing their dose and so on? So really establishing goals when we start somebody on an opioid, when we escalate that dose, and implementing routine and regular evaluation of their therapy. This is really discussing the risks and benefits of using opioids. And again, we brought in some connections to our own ThedaCare policies to do with this as well. All right, so how did we do on this initiative? We had a few different bold A metrics. Within 6 months of establishment in that clinic, 100% of our providers will receive an academic detailing visit. I'm smiling at myself because I go big or go big or go home, right? I don't know. So 100% was our goal. We got to 98.5% acceptance of an academic detailing visit. Understand that we are in an embedded program, certainly. So, you know, it should be a lot easier than an external organization, for example, but completed 132 visits representing 98.5% acceptance. Our clinical metric was within 6 months, no more than 20% of patients with an MEDD greater than or equal to 50 will not be co-prescribed naloxone. I emphasize the no's and the nots. It's a double negative statement, which drives me crazy, but it is how our electronic health record formulated that rule. So you have to think about this. You actually want to get closer to 0 than to 100. And our goal was no more than 20. We did achieve 28%, but an adjusted rate of 14%. Adjusted rate because there were some flaws, if you will, or imperfections in the electronic health record database. So truthfully achieved 14.1%. Within 1 year, we will reduce the number of chronic opioid patients who are co-prescribed benzodiazepines by 15%. We achieved this within 4 to 9 months. The range is because I had various stages of implementation in terms of my program. We weren't able to implement pharmacists in every call group at the same time. Importantly, we have 144 fewer patients on opioids and benzodiazepines. 136 of those were from pharmacist embedded clinics. Those numbers are huge. I like this one because to me, it tells the importance of distinguishing between a percentage metric and a number metric. Number 144 seems to be just so much more impactful than that percentage. And we also partner in taper referrals, tapering patients off of those, and we received 142 taper referrals. Some deeper dives and lessons learned on this, always encourage you to understand, challenge, and question your data, then adjust your rules within your electronic health record as you learn more. So here were some reasons for why the patients were not ultimately started on naloxone, with majority of them being what we call a falsely high MEDD. In other words, the patient wasn't truly taking that much of it, but the database showed it to be that way. Fewer is better relates to my metrics, and I've learned this. It was my first initiative, and I went hard with a lot of metrics, but that means a lot of tracking. So fewer metrics sometimes is better. Our next initiative that we are undertaking right now relates to diabetes. So we have 3, see, I've already taken my lesson, 3 metrics only. The first one is for our physicians as well as our ACO family, if you will. We will generate $372,000 in annual savings through eliminating DPP-4 and GLP-1 co-prescriptions as they have duplicative mechanisms. Second is academic detailing. Every provider will receive a one-on-one session with a pharmacist to discuss pharmacotherapy for diabetes. The third is really understanding the pharmacist's impact on A1C. We all know that we have great impact on this, and there's a lot of literature to do that. Yet still, we wanted to provide a more specific measurement for our own organization. We are tracking new referrals for ambulatory pharmacists for diabetes medication management to measure the change in A1C from time of referral to 12 months later. And that's our current initiative. Here are some brief snapshots of our materials for the diabetes initiative. Again, some key messages using GLP-1s and SGLT2 inhibitors in patients with compelling indications, even if their A1C is at goal. Utilizing the ambulatory pharmacists to optimize guideline-directed medical therapy. I call this the shameless self-promotion, which you have to do. And really, what is the role? We got that question asked often. We're getting it less and less, but when do I refer a patient to you? Why would I? For what reasons? So this is really highlighting how we can assist in diabetes patient management.
All right. Any final words, Nicole, before we open it up to some Q&A? All right. So here we go. Thank you so much, Nicole. We do have a question fresh out the chat box from Carrie Meyer. She says, this is great information. What kind of advice can you provide for those of us who are non-pharmacists so that we can disseminate the information correctly and yet present competently? Any thoughts on that?
Well, I think it would be, depending on your role, is you utilizing that opportunity to highlight your area of expertise and your role. So certainly staying within an area that you feel confident and competent to be able to speak to. And when you think about diabetes, for example, my goodness, that's a great example of the roles for a health coach, for a diabetes educator, for a pharmacist, for a physician. There's so many different roles. So it would be, my advice on that would be simply to really hone in on what you feel is something that you can contribute uniquely to that patient population. It could be social determinants of health as well. I mean, there's just so many different ways. So that would be my thoughts on that question.
I love that, Nicole, because what you're saying, kind of, if I may translate, and you can tell me if this sounds right, is you don't have to imitate somebody else. You can bring what you bring in your unique role, but also connect with other folks from that coordinated care team to kind of learn peripherally from them, but also be, in the role that you're in. I also loved, the other comments you made that I just wanted to call out. How you show metrics is key, the way that can be impactful in what you share with clinicians, and the idea that tracking too many metrics can be overwhelming and also maybe not necessary when you think about to whom you're reporting. And I love that Elizabeth Garcia from New York says, figuring out your detailing superpower. We don't all have the same powers. All right, we don't have time for another question just yet, but Nicole, please feel free to answer in the chat. We have a question from Lauren and some comments from Zach that are all very much giving you the accolades you deserve for this great work and great presentation. Thank you so much.
Thank you. And thank you, everybody. You're filling up my bucket.
All right. Anna, let's see who we're going to close up with before we head to lunch today.
Yes, and thank you again, Nicole, for a great presentation. We also have a fabulous blog interview that Anshul did with Nicole that is up on our website if you'd like to learn more about her work. All right, we are going to jump back on the AD bus and head down the Evidence Road to California. We are going to hear from our colleagues at Kaiser Permanente. I'm excited to introduce Meisha Draves, the Medical Director of Pharmacy at Kaiser in Northern California. She collaborates with physicians and pharmacy within an integrated healthcare system to set direction, as well as implement guidelines, policy, utilization strategies, research, medication safety, and operations. I'm thrilled to turn it over to Meisha to share about how her team has used academic detailing across an entire health system to increase the use of biosimilars. Meisha, we are ready for you to join us and take it away.
Oh, thank you so much for having us here today. I'm also a practicing family medicine physician, so much of what I'll share with you today about our system, we implement and then get to use when we're caring for our own patients. So I have no disclosures or conflict of interest, either financial or non-financial today. And also with me is David Chen. He's a pharmacist who collaborates with us, and he may help us in the chat with some of the questions today, for which I probably couldn't do a lot of this work without wonderful partnership with our pharmacists. So in Kaiser Permanente, we have 12.4 million members. We're in 8 states. We have over 700 medical offices, almost 40 hospitals. We have over 23,000 physicians, 63,000 nurses, and in addition, we employ over 200,000 individuals. Next slide. Our pharmacy in our integrated system is quite unique. We sell about 93 million prescriptions, 56 million doses administered in our hospitals, and 7 million in our infusion clinics outpatient. We have over 500 pharmacy sites. We employ about 14,000 pharmacy staff members, and we have over 200,000 interactions with our members each day. Next slide. So today we're going to discuss biosimilars and how we use academic detailing with our physicians, our pharmacists, our nurses, and of course with our patients as well, really to improve the uptake of biosimilars in our population and relative to the US market. So just very quickly, in case anyone says, what's a biologic, what's a biosimilar? So biologics are large, complex molecules, and they're grown on living cells. So you can't replicate them exactly in a test tube. Biosimilars are sort of like the generic to the brand, but here they're highly similar and they don't have any clinically meaningful differences. However, they're not an exact copy because they are grown on a living cell. To that effect, when they go to the FDA for approval, unlike brands and generic medications, they do have to go through some additional analytical scrutiny. They have non-clinical tests, they have clinical pharmacology tests, and they do actually have to do a clinical study in at least one indication to prove that they're non-inferior to the biosimilar. So they may not be an exact match batch to batch. However, they are so highly similar that we call them biosimilars, and they have additional scrutiny at the FDA in order to come to market. Next slide.
All right, we got a poll, much excitement. I think it might be one of the last ones before lunch. So the question is a yes, no, or unsure question. Do you incorporate academic detailing on biosimilars to physicians, pharmacists, or nurses? Let's see where the poll takes us. And if you're unsure, not to worry. All right, so it looks like we've got a pretty strong lead on no. A couple folks are unsure and a couple folks are quite sure that they do. But we're seeing a strong lead with no. So is that surprising to you?
So I think, this has been a journey for us as well. And you'll see we had to learn as we go, and who had to be part of the academic detailing, because much of this is done in an infusion clinic. And so we learned along the way. And so I'm not surprised that the answer to all of them are no, because we learned along the way too. So I'll share with you our Kaiser Permanente approach to evidence-based medicine, academic detailing, and really driving the quality, safety, and affordability of our care. So why did we move to biosimilars? They have equivalent efficacy and safety compared to the original product, and they're often there to reduce costs. This is very similar to the introduction of generics in the market in the 80s and the early 90s. There were initial concerns about efficacy, safety. It took many, many years to develop the acceptance of generics. So we know it'll take many years to develop the acceptance of biosimilars. However, they're really key in providing additional access to care, affordability to care, and even driving competition in the market. And so, with those increased options, that increased access, that increased affordability in care, we're really able to bring more treatments to our patients and to patients across the nation as this competition spreads across the US. Next slide. So, analysts say that biosimilars are tracked to save the US, reduce US drug expenditure by about $133 billion by 2025. So the uptake is definitely on the way. We really leveraged our brand to generic process to gain trust early on. We started with very slow education to our providers. We really relied on evidence-based decision-making. And then we looked at a lot of real-world evidence on equivalency and cost effectiveness. And then we actually partnered with other countries and then continued that cycle of teaching, using, learning, and then repeating. So we really started with endorsements, meeting with our key physician and pharmacy partners to develop the presentations and gain stakeholder approvals for the use of biosimilars in each disease space. We worked with our contracting teams to secure contracts for our biosimilars. We added the biosimilars to our formulary process, vetting through our pharmacy and therapeutics committees. We used huge education campaigns through our drug use management to physicians, pharmacists, nurses, all engaged in the use of biosimilars. And then we really leveraged our operations in the electronic health record, at the ordering point of a biologic, and also implemented inventory strategies. And then we tracked our utilization. We re-educated where needed, and we additionally monitored for safety and efficacy where our physicians or our nurses or pharmacists may have wanted additional information as we continued on the journey. At Kaiser Permanente, our ability to move that market share to really affect our purchase volume, while small, 12 million members, 4% of covered lives is small, it has huge leverage. And we've been able to deliver over 90% market share for each biosimilar that we use in very short periods of time. Next slide. So our education really followed these 5 main principles. Is it effective? Is the biologic safe? Are the presentations the same? Meaning, is it an infusion or an injection? If it's an injection, is the injection type that a patient has to give to themselves the same, or do we need to retrain them? Are there differences in the patient convenience of the use of the medication? And of course, which ones are more cost effective? So our biosimilar experience, we really had to gain a lot from Europe and really get external input, where many of the countries in Europe had started the biosimilar experience far before the United States. And we also became very dedicated to pharmacovigilance efforts and contributing to the evidence ourselves. Many of the tools that we use are tools that you all probably use in a virtual space became quite interesting as well. Flyers, posters, FAQs with many presentations and pocket guides with talking points, newsletters, utilization data. And for our members even, we had to educate with handouts and letters and phrases that our providers could use over email or telephone conversations, as well as posters in exam rooms and news articles. As much of this has been done in the virtual space, we used a lot of our virtual platforms to speak at lunch and learns, to speak with our physician leaders and chiefs groups, to discuss in clinical pharmacy meetings. We would even have one-on-one sessions to help our providers with their individual patients and discuss, as well as physician department meetings within a specific specialty. Next slide. So it was interesting. Each audience really was focused on different parts of the knowledge base in biosimilars. And as our academic detailing went on, we had to change the focuses in order to really understand our audience. So for physicians, really, of course, they wanted to know the efficacy. Will my patient's outcomes be the same? Will their disease state be treated just as well as if they were on the reference product of the biologic? Is it safe? Are we going to cause more problems? Immunogenicity. Are we going to cause the patient to develop antibodies over time by switching? When there are studies on a biologic, they only study in one clinical indication to show that they're biosimilar to the reference product. So how do we extrapolate to all the other conditions? What are the treatment categories? What are the patient educations that are needed? How do we deal with new patients who are just starting a treatment versus existing patients who need to convert? And then very importantly, our physicians wanted to know that we would use our experience to contribute to clinical trials and the evidence that was growing on biosimilars. Next slide. We realized that we really needed to talk with our nurses and those in the infusion clinics, as they were huge portions of our patient education and communication. Our nurses are huge advocates for patient safety. They really needed to know that what they were giving the patient, what they were starting an infusion for, was safe. So there's a lot of education around that, as well as infusion time. Is this going to take 2 more hours to infuse? You know, and then in addition, very operationally, how do we prepare this? What is our stocking and our supplying? What does the formulation look like? Is there a different way that I have to administer this? So we really needed to tailor our academic detailing to our nurses and what they needed as well, and so that they could be good, strong advocates to our patients. Next slide. And finally, both our pharmacists as well as our leaders in administration, they wanted to know that what we were changing to was effective and safe. There was a lot, again, on supply and stocking and preparing the medications and formulation presentations. They also wanted to know about patient copays, because biosimilars are less expensive. Their co-share at an infusion may be more affordable for them, providing them more access to care. What are the reimbursement rates like to a health plan or to an infusion clinic? And a lot of information about patent litigations and evergreening. Next slide. In addition to all of the academic detailing and really honing it in on our different audiences, we promised to our physicians, our pharmacy, and our leaders that we would also contribute to the evidence. And so we did retrospective real-world studies on biosimilars that did not show safety or efficacy concerns, say with trastuzumab. We also did studies on filgrastim. We looked at infliximab in inflammatory bowel disease, where our physicians were very concerned. If I convert a patient, is this going to lead to a flare-up? Is a patient going to end up with a colectomy? Am I doing the right thing? And we were really able to study and show that there was no inferiority. It was a non-inferiority study. The biosimilars that we were switching patients to were just as safe as the reference products they began with. And we did similar studies with bevacizumab with metastatic colorectal cancer. This has been a very important virtuous cycle. We look at the evidence, we do academic detailing, we implement, and then we study ourselves, 1, to reassure internally, but 2, to be contributors to the real world evidence as we move forward. Next slide. In the United States, between 2018 and 2021, the average uptake of a biosimilar is anywhere from 33% to 74%. And so over the past few years, the uptake has begun in the US, very far along in Europe, where we originally learned most of our academic detailing from. But in the United States is well underway as well. In Kaiser Permanente, we've really had an uptake between 88% and 99% for biosimilars. We use evidence-based medicine, we educated, we had the physicians endorse the safety and efficacy. We put in decision support in the electronic medical record. We monitored the implementation and uptake, as well as monitored for any switchbacks, and then contributed to the evidence. Most patients said they were satisfied or very satisfied with switches to the biosimilars. And we had an estimated savings of over $500 million attributed to switching to biosimilars. And you can see here, the switches are pretty rapid. Once we make a decision, within 2 to 4 months, we have pretty full switch outs from the reference product to our biosimilar product. Next slide. So I really want to say thank you to many of our physicians, our pharmacists, who really drove biosimilar use, and what we continue to do today. I think we're on sort of our 7th one, and in 2023, we're looking for more. So thank you so much.
Thank you. We're so excited to have a few minutes to reflect, and also to thank David, some of your awesome responses to questions are actually going directly to me. So if you can pop those answers in the chat so everyone could see them, that would be great. Maisha, we have some sort of questions, I think, across the audience that are very much about how to apply some of this. I know David responded to quite a few. We do have one from Paul Finicos of Velosa that has a couple questions. Did you roll out all the products at one time, or did you schedule overtime? And then he asks or references that generic transitions take about 6 months. Is that true about your project?
Yeah, so very interesting. We started this journey back in 2015 and 2016, and there weren't many biosimilars on the market. So we were able to really go with one at a time. And I'd say every year we would launch 1 to 2. In the beginning, it was very slow, and we took our time, really all of that academic detailing that was necessary to get the first one going. And then using that experience and having those physicians, I think in the oncology treatment space with Phil Graston and in the supportive care space, to then talk with the next group. We were able to go through that transition. We can trust this data and evidence, and that what the experience they had as physicians as well as the patients with those transitions. So we very much started with one at a time. I think now we have our feet under us and can do more, but that's been quite a journey of 7 years.
Awesome, thank you. So much to learn here. One final wrap-up question. We have a lot of folks for whom, this is, heavily ensconced in, a physician lens and a pharmacist lens. If there was one nugget you think you could extract, and this is perhaps a tough question or too much of a broad question, but to put you on the spot, if there is a nugget you could extract that you learned from this process that you would offer up to any academic detailing program, what do you think would be something that you would say, please don't forget to do X?
Yeah, probably what I didn't say in all of this and mention is this all has to be co-designed. So the system implementing along with the frontline physicians who are caring for the patients and writing those prescriptions, we designed all of our materials together. We read the evidence together. And so this entire journey was a co-design. And therefore, it wasn't put upon our physicians, it was done in conjunction with our physicians. And I think anytime you can co-design along with your audience, the uptake over time is going to improve. It's a very go slow in the beginning to go fast in the end method that I think over many years has proven quite a success in our program.
I love this, the idea of co-design, really making sure that you're sort of testing this out and bringing them in. So you're not spending all this time getting ready and then having this sort of pushback or lack of acceptance here. A lot of really great reflections in the chat box. David, I know you have your work cut out for you, continuing to answer these over the next few minutes. Thank you so much to both of you for representing Permanente and sharing all these great insights. You have a lot of nice feedback in the chat box that I hope you'll have a minute to reflect on. Over to Anna to get us over to lunch.
Yes, and thank you, Misha and David. So we are about to head into a 45-minute break. After break, we're going to go into our breakout sessions. You can find descriptions and Zoom links to the breakouts at narcad.org/breakouts or in our program book. Like yesterday, you can choose one breakout session to attend. The breakouts will not be recorded, but slides and materials from each breakout will be shared on our Conference Hub webpage after the conference, so you won't miss out on anything from other breakout sessions. We have a session on taking lessons learned from a rural state and applying those lessons across diverse geographies, a session on team building, and a session on developing materials for effective in-person and virtual visits. So please do enjoy your break, and we'll see you in breakout sessions at 1:15 p.m. Eastern. Please stay connected to this Zoom room and just turn your video and audio off if you'd like to continue the conversation and network with colleagues in the chat box. If you decide to stay in this main room, Bevan will let you know when it's time for you to transition to breakouts. And you can join the breakout links anytime before 1:15 p.m. Eastern. Just know you will be placed in a waiting room until showtime. So please do take a nice stretch, grab some fuel, and we will see you soon. Thank you, everyone. Bye-bye.
In about Thank you, Angela. We're going to kick back up in about 30 seconds. Hi, everyone. It is 3 o'clock Eastern. We are excited to kick off our final session for the day, where we'll talk about building capacity on an expert panel and take a bit of a peek at the idea of training the trainer, something that we have been working on fiercely and ferociously here at NaRCAD. But also steadily over a period of time to start thinking about how we can support you all in building capacity across the US and the globe. So let's dive right in. We want to make sure we have plenty of time for this panel. The first thing I'd really love to do is just introduce these fabulous folks. So first on my left here on the screen, we have Julia Barham. I had the privilege of meeting her about 7 years ago to do a 101 session at, if you can remember, in-person conferences, which we will get back to next year. Julia is a pharmacist with RX Files Academic Detailing Service in Saskatoon. You may have seen her earlier today join the Canadian gang to do a little woot woot for our Canadian turned Wisconsin speaker. She's also a community pharmacist. And her work at RX Files includes doing AD across the whole province of Saskatchewan. She's has fabulous insights and has been doing detailing for some time now. So anything she shares, is something that you can trust has the take from a seasoned pharmacist and also one of our very own training facilitators. So welcome, Julia. We also have Jessica, or Jess Allward. She is an academic detailer in New Hampshire, specifically out of Concord in the northern part of the state, but also tends to work across the state. She works for the Bureau of Infectious Disease Control at New Hampshire Department of Health and Human Services. And one thing that's great about Jess, or of many, besides the fact that she has a background in theater, which is always helpful to be an academic detailer, is she focuses primarily on HIV, STIs, and other infectious diseases. She also helped to develop the public health education and detailing program, which provides education to providers, organizations, and New Hampshire residents. She's been a training facilitator with us for about 1.5 years now, maybe a year. Am I getting there? Is it almost 2? Almost 2. And we're happy to have her joining us just one state up north. And down in the southeast of the country, we have Shushan Shukla from North Carolina. He serves as the Mountain Area Health Education Center faculty physician and the clinical director of health integration. He is one of our newest training facilitators and is the lead on various initiatives and projects at MAHEC around addiction, HIV, hepatitis C, homelessness, and looking at the criminal justice system. So we have a nice cross-section here of folks to talk about how they got into academic detailing. We're going to talk about being a trainer, building program capacity, both their own programs and encouraging you all to do the same, and just sharing the hot tips that folks who've been doing this for a while can share with all of you. So do start thinking as we go about questions that you have. Depending on what comes up, I may weave them in as we go. So don't wait till the end to ask your questions in the chat box. With all that to say, thank you so much for being here, the three of you. And we're going to start with a poll. So if you have yet to join Poll Everywhere, you'll want to send a text to 37607 with the word NaRCAD1108. For those of you who are already ready to go, we're going to ask you a question. For those of you who are catching up, go on ahead and type that into your text message. So yes, no, not sure yet. Are you actively trying to build your AD team? All right, not yet. Ooh, okay, we're going to see these things go back and forth here, I have the feeling. All right, so yes is taking the lead, which is great. Some folks who say no might not only be saying no because they're not ready, they may also not have the funding to do this. Not yet is nice to see because that means they're thinking of doing this. And again, with the no, we want to know a little bit more. Go ahead and pop into the chat box why the no's, if there's anything beyond resources, not finding the right staff, things like that. All right, thank you so much. So what I would love to do is talk a little bit about growth and growing your team. And I'll throw this first question to Jess from New Hampshire. Jess, what are the things that you would share about trying to build and grow a team? Especially since you were a team of two and now you're still a team of one, is that correct?
Yes, so for the last 3 years, I'd spend just me in the entire state of New Hampshire, detailing on everything infectious disease. I always tell people, if you can catch it, I will talk about it. So what came out of COVID for us was one good thing in that we got some funding for an additional detailer. So
wonderful.
she's on actually here at the conference today. Hi, Amy. So we've been able to hire a second detailer and I'm thrilled to have her come on board and begin, figuring out how to work the state as two of us instead of just one.
Yes, that's wonderful. And it may not sound like a big, change to have one more person on a team, but when it's a team of one and you're turning it to a team of two, that's a big, big change. Jess, what would you say are the suggestions you would offer to someone in the audience who is also anywhere from a smaller team to a larger team to say, what are your expert tips when you're thinking about growth and capacity building?
So learning through experience, a little trial by fire here, and having this come at us really suddenly, I would say that if we were going to rewind a little bit and kind of look at this again, knowing some of the bumps in the road, it would be to plan before you actually started to implement and hire and all of those kind of things. I think really developing what your policies might look like for a growing team, a set of procedures that you want to maybe have in place so everybody's working in the same way, working toward a common goal, and then really thinking about the kind of person that you want to bring onto the team. Are they a good fit for the people that are already working there, which Amy is? And also, do they have those really key skills that a detailer needs to have?
So we're talking about your tips being, get those plans in place before you hire, which might sound sort of obvious, but some folks may have to ramp up really quickly. And so getting some butts in the seats, as it were, might be something that folks feel the need to get to quicker, especially if there are time restrictions on grants. So thank you. And of course, considering who you're looking for, there is that sort of ideal detailer that we talk about here at NaRCAD around recruitment with, really savvy communication skills, terrific knowledge of the clinical evidence, but also how might it be different for your team in New Hampshire versus a team somewhere else? So considering what's unique to your program. Lovely, Jess. Thank you so much. What I would love to ask you about a little bit more as a group is going to be inspired by this next poll. So hop on over to either the chat box or your phone. What word would you want to be able to use to describe your team in 1 year? So everyone who's in the audience, even if you're not thinking of growing your team, what would you like to be able to use as a descriptive word? All right, here we go. We're going to do a word cloud. Confident, expanding, yes. Successful got big, effective, busy, intact, thriving. Functional is a great goal to have. Diverse, successful, yes. Look at these words getting bigger. Engaging, competent, passionate, recognized, brave. I love that one. Taking risks. Sought after, lots of great words here. Caring, that's a beautiful one. Powerhouse, yes, powerhouse team. We'll do a couple more. Thriving, dynamic, keep saying functional and laughing a little bit about that, but yes, these are all things that are either aspirational or things that we just really need to have happen to make sure that a team is positioned for success. So with that in mind, I want to throw a question over to Julia. Julia, would love to talk to you about leading a larger team. You've come from not only RX Files being a bigger team, but also the interconnectedness of the different teams and organizations up in Canada and the ways that they inform each other's growth. You really have sort of neighborly relationships, if not really close relationships with these different groups like BC PAD, CEP, and so forth. Can you talk to us a little bit about how you learn from each other, either on your own team or in that broader community of detailers, and some other things that you would see as critical to address to keep team morale high?
Great questions. Thank you. I'm writing down my thoughts because these days, if I don't, poof, they're gone. So how do we learn from each other? Well, I think that's an easy one. We just engage with one another. I think naturally as humans, we're social. We love to talk. We love to support one another, and making the time to connect with our team members or with other organizations to learn from them, I think is really valuable. So internally, how do we learn from each other? Well, of course, we do our formal training on our topics. We do 2 new topics every year, and that's a great opportunity to have those team discussions. And then once we're out in the field, sharing the questions we've come across when detailing a variety of providers, to sort of give our colleagues or other detailers a heads up so they can be prepared, because if one provider is asking those questions, perhaps another may ask that question as well. Having those debriefs after, especially the initial detailing sessions, whether you knocked it out of the park or you just had a really bad one, just picking up the phone and saying, "Oh, this did not go well for me today, and here's what I think happened," and just getting that support, as well as just being like, "Yeah, killed it," and sort of teasing apart what made that session so successful, so that hopefully you can repeat that success in the future. And then having the opportunity to connect with other programs across Canada, and Taryn's on the call, and Kyle for sure, they're from BC. Learning from others, right? Especially, it's always nice to learn from someone else's mistakes, but also to beg, borrow, and steal other people's great ideas and innovations has been certainly invaluable. Certainly makes you a more efficient team when someone has done all that background work and is happy to share their expertise and times and lesson learned with you.
That's awesome.
Do you want me to
keep
stop
going,
there?
keep going.
I was just going to touch on morale, because I think it is really important. And when you take care of your team and your people, they'll take care of the work, and they'll lift each other up, and they'll support one another, and we'll leverage our strengths. And I'll go, "Oh, I know you're really good at that. Can you help me with this?" Or, "Hey, I'm happy to pick that up." And team building, I think it's more of the informal thing, and it happens outside. Generally, not always, of course, but I think you need to make that effort outside of our formal training. And when you come together for a few days to train, what are you doing at night? Are you going for supper? Are you going mini golfing? Are you going bowling? You can have a great time doing that. Currently, we're collecting some donations for a charity, and we've challenged some other departments at the university, because turns out we're a competitive bunch. So things that we can share together and sort of reward ourselves and give to others as well has been something that just a few things that helps us sort of build our morale on the team.
Amazing, Julia, and get that flavor. Having worked with so many Canadians over the years, it's like a positively, supportively competitive bunch. So I love that, and I love putting some notes in the chat here. I love this comment from Jen Carefoot, who presented yesterday about how RX Files and BC Pad often detail each other for practice. Again, if you're a small group or even if you're a larger group, let's get you practicing some of these things with us, with each other. And if you don't know anyone yet, let us make recommendations. So if you're in a state that's dealing with a particular topic and challenged by a specific geography or a kind of pushback, we can connect you with another group who's having similar issues or has been successful in that area and get you together for a little bit of theater and a little bit of trying it out. Julia, I love your suggestions about informal team building. Some folks who are more introverted or just want to be done with work at the end of the day might not necessarily work for you. But one thing that Anna and I have discovered here at NaRCAD is having something that's in between formal and informal that doesn't necessarily require time outside of work if your schedule is booked, is doing something that's professional development related, where it's something like a book club reflection or something that really feeds and nurtures your desire to continue growing in your field, but takes it away from that formal, structured training 8 hours a day for 3 days piece. So again, thinking about and inviting each other to build peer interactions is another great way to go. I love these suggestions. We have some really great notes here from Kyle. Sharing what seemed to resonate with clinicians is of great value when planning a similar topic. So let's say you're a state working out there on opioid safety and you haven't been in the field yet. Rather than waiting for a first wave of field work from your program, come check in with us and we can say, hey, Tennessee's done that. You have a similar geography. Let's get you on the phone with them to see, hey, practitioners and pharmacists were particularly prickly about this piece, but maybe over here with nurses, this is an inroad. So again, peer connection is something that I know all three of you do really beautifully and are really enthusiastic about. All right, we have another poll here. We're going to explore a little bit more around team building and a bit around capacity building here. So I'm going to ask you all to pop back on up to your telephones, and we will ask you one more poll before we answer a question. Ask a question of Shuchin. What's a priority area for capacity building? We have expanding my team is A, B, training staff on new topics, C, geographic expansion, D, acquiring funding for new initiatives, or E, all of the above. If it's not all of the above, but there's two things, please go ahead and in the chat box, you can type A plus C or B and D. So here we go. Training staff on new topics is taking the lead, not by too far. We also have expanding team and acquiring funding, even at about 16 or 17%. So training staff on new topics seems to be taking the lead. And, it also seems like there's a good chunk of folks who really want to hit a little bit of everything. This is not surprising. There are so many areas for programs to try to grow with or within. So I would love to ask a question of Shuchin. Shuchin, what do you think is the top priority area in general for your group when trying to explore capacity building? What have you experienced, and within that experience, what would you recommend to folks who are in the audience to try and emulate or not emulate? Did we lose you? All right, it looks like
He's on his phone now,
Hey.
Bevan. Hey, Suchin.
oh, there you are.
Can you guys hear me okay?
We can. Thanks for coming back to us. So
Sorry, the Wi-Fi is bizarre on campus today, but I'm on my phone, so that should work.
great. Were you able to hear my question?
Yeah, about capacity building. So I think partly I should explain what our program does. We are an opioid-specific topic program, so we do a lot of education in a variety of ways. The typical didactics, teaching residents and medical students and specific learner groups through like formal education programs, and then things like academic detailing and CME accredited education venues. So in that context, capacity building for us has been more driven by the topic, and that has been sort of easier to build capacity around because there's just a ton of funding. So I know in the poll that funding for positions has been an issue, and for us, because academic detailing has been deemed by the CDC to be a evidence-based intervention for public health intervention for the opioid epidemic, that's actually given us a really powerful niche across North Carolina to be able to provide that service in a variety of ways, particularly now that we can do it virtually when it was a lot of driving prior to the pandemic to do that. And then additionally, we are an organization with multiple disciplines that work side by side. So pharmacists and family docs. I myself am a family doc, different kinds of students, behavioral health providers, psychiatrists. So depending on the audience or the target for the academic detailing, we have a variety of experts that can provide that. So I work as more of the leader of a team. We do have some folks that are family docs that were trained through NaRCAD to be detailers, but that's allowed us to build up capacity both in terms of funding to do that work, having, as Bevan put in the chat box, local experts who are both treatment providers as well as trained educators. That's really allowed us to expand our footprint in this direction with academic detailing.
Awesome. Thank you so much. And I liked what you said about training and getting staff to a certain, sort of spot being a way to kind of make the case for continued funding and continued capacity building. Obviously, there's different ways to approach this based on if you have initial funding, but if you can show through early work with your academic detailing programming, by thinking down the road to wanting to continue, if you can show your successes to folks who have funded you, they are more likely to be able to continue your funding. And so thinking about, do you have other funds that could sort of, be seed money in a way to get things going and then be able to show your results to funders or potential stakeholders in the community. So that's lovely. And, we're talking about other things around geographic expansion and acquiring funding. I'm wondering if you could speak a little more too, Suchin, around the CDC funding. Are they your sole funders in regards to academic detailing?
They are one funder. Let me think. So another funding source is through our state HHS, probably through a block grant like the state opioid response funds, which I think ultimately comes from HRSA, though I can't be sure. But it's been helpful because one of the main folks in our Department of Public Health at the state is a pharmacist who is the one that really brought this to us of saying, hey, y'all should send someone an NaRCAD, and hey, y'all should do more academic detailing. So, I mean, I would say we were blessed in that way, but also, the CDC has published reports that say that academic detailing is an evidence-based intervention alongside things like naloxone distribution and access to MAT. So it's being put forward by CDC in the US as on par with these other public health interventions. So I think there's a strong foundation to stand on with that. The other thing that's been helpful, just to plug NaRCAD, the N in NaRCAD is for national. And so it's easy for us to say, hey, we are partners with like the #1 resource center for this intervention in the US. And they helped us design some of our data collection tools. They obviously trained us and then trained me to be a trainer to provide these services. So it was an easy lift to convince the funders that like, hey, y'all should fund this. And so we think we'll be at the front of this for years to come, as now we're seeing a new source of funding, which is the opioid litigation money that's trickling down now through state health departments and even, at least in North Carolina, through county health departments. And so we can see ourselves not only continuing this with opioids, but parlaying this to other public health topics that do have funders, such as like HIV and probably Hep C as that comes along, and other mental health issues, because, you know, it's clear that the federal and state health entities are going to fund this because they are such big public health problems.
Thank you. So many nuggets there. A couple I want to focus on are thinking about the idea that, you know, diseases do not and conditions do not exist without thinking about other ones, right? So thinking about infectious disease, with, you know, Jess, you originally, if I'm not incorrect, started with HIV and then expanded to STIs and then Hep C. Do you want to talk a little bit about how that happened and how you might encourage folks to make the case for, you know, sort of peripheral challenges and other situations where there would be comorbidities to sort of, you know, pitch for additional funding or support?
Sure. For us, it really, you know, HIV, PrEP, and PEP was the logical place to start because we had a great team of folks working in public health around all things HIV. We had a great Ryan White Care program that was there to support us. So we started with a topic that we felt like we had some really good subject matter experts on available to us. That was of real interest here in the state of New Hampshire for providers to know more about and to really become prescribers, to kind of help end the epidemic. And then as we began to be more comfortable in what we were doing and we built those relationships with providers and they knew who I was and they knew who the Fed team was and they felt like we were a valuable resource, that's when we felt like we had the capacity to take a look at things that maybe we weren't so familiar with and figure out how we can detail on those as well. So we have a great hepatitis C coordinator who works with us. We pulled her in. She's working on an elimination plan and we're figuring out, you know, how to use some of the stuff that she's already come up with and working with a great tri-state group in Maine and Vermont on that. Like, it's figuring out where you are in your work and starting from a place that feels comfortable and confident, and then finding ways to kind of step outside your comfort zone, but use those resources that you have available to you. Great in-house subject matter experts, all of the people you can connect with at NaRCAD. I can't tell you how much I've learned from Julia and Jackie and Vishal and all of you, and they're always there. So feel free, if you're building a program, to reach out to those people and say, hey, how did you do this? What am I going to run into for obstacles? I think this is really important that we find a network of champions that can support and uplift programs across the country.
100%. And again, we are here. We are funded to help you. So please, also, we want to know who's talking to who because we're kind of nosy. So let us know who you want to talk to, so we can be the matchmaker, and also so we can check in and say, you know, I heard you wanted to chat with Jess. Did you get what you needed from her? Do you want to be on a group call or join a session, you know, with peers across the globe to talk more about this specific subtopic? Whatever the case may be, please put us to work for you so you don't have to do it all by yourself, especially if you're a newer or smaller program. All right, so I'm seeing a question in the chat box. We're going to open up to a few more chats. Question from Elizabeth Garcia in New York. Thanks, Elizabeth. You know, it's also a reflection. It's been extremely difficult to get people to apply to open positions at our health department. Where do you go to recruit detailers? What types of career outreach do you do? And do you tend to hire clinicians or non-clinical detailers? Julia, I'm going to turn to you since you have probably the largest of the three teams, so we can just talk about that. And then we can also offer some resources around recruitment, but take it away.
Oh, I don't know if I'm the best person to answer this because I'm not sure my response will be very insightful. RX Files really focuses on the optimization of drug therapy, and we're funded through our provincial drug plan. So pharmacists are who we target to hire. So we're all pharmacists with the exception of our admin support, of course. So we do always go after clinicians. And I'm not sure what the environment is like in the US for your big sort of pharmacy chains, like your CVS, for example. Here, community pharmacists are looking for a change. They're overworked, they're getting just killed every day. So when we open up a position, having applicants is not a challenge. Perhaps finding the most appropriate applicants and very qualified, not many people have academic detailing experience as a challenge, but I dare say we've been fortunate enough to not really struggle in that department.
That's excellent, Julia. So again, thinking about, let's translate what Julia said, which I loved also that you said, go after the clinicians. That sounded exciting. So think about the goals of the intervention. What are you trying to accomplish? So if you are more focused on an intervention around changing prescribing and medication, that may be something where a pharmacist may be best positioned, or at least better positioned to do that without a lot of extra training. You really want to think about your audience too. Are you going to speak to mostly pharmacists? Would it be helpful to have a pharmacist to pharmacist approach if that's the case? Think about who it is, what you're asking them to learn, and thinking about, especially if you have the time to do some focus grouping, thinking about from whom the message might be best received. And so we have seen folks succeed across just a spectrum of different academic detailers with such varied backgrounds. We've got social workers, we've got folks like our friend Lisa Webb, who spoke yesterday, who has a background in counseling. We want to stress so much that the clinical background is critical, but if you are a clinical expert and you don't know how to do that sort of back and forth communication and you're more of a lecturer, it might not be the best match for you. So again, you want to think about what you're communicating to whom, and also, thinking about how much time you have. You may think, hey, anyone could do this fairly well, but we have such a limited amount of time to train that we're going to go with pharmacists because it's a medication-based intervention. Elizabeth, does that help? And is there sort of anything else you want to add to that question?
It does help. Unfortunately, we can offer salaries that are much lower than the average community pharmacist makes. So I haven't had that much luck reaching out to my pharmacist network, unfortunately.
One option there could be also looking at final year pharmacy students or graduate students. That's something that we've seen work with varying success. And when it's been successful, a big part of it is that there's a lot of flexibility in scheduling because they're not in practice, 40, 50 hours a week. So thinking about that is definitely something where getting to put something like that on a resume for someone who might be not fully into their career yet could work. So again, if you don't have a lot of funding for hiring, thinking about that might be a way to go. I want to throw it over to you, Jess, and not to put it on the spot because we have your new colleague in the audience, but what were a few things that were critical that you were looking for when hiring for the position that Amy is now in? What did you feel like was non-negotiable?
Well, it's funny because I did not actually get to sit in on the hiring process. What I did get to sit in on was kind of rewriting our job description to include some of these key attributes. Let's go with that. That's a good word. And what we really wanted in someone was someone who had really good relationship building skills, because that's really what we focus on here, is we want to build strong, ongoing relationship with all of our providers here in New Hampshire. We wanted somebody who had great critical thinking skills and was a really good communicator. And most importantly in that communicating thing, it's about listening more than talking, right? So we wanted somebody who was going to be able to ask some questions and then sit back and really absorb what the providers in New Hampshire were trying to tell us was a problem or was a challenge or what was causing them stress or anxiety. And we were very lucky to find Amy. We were hoping to grow the program even more, but much like Elizabeth was saying, being a state agency, our salaries are not that high. I can tell you, and she won't care if I say this, that Amy didn't come to us for the money. She came because she wanted a kind of different work environment. She wanted to feel like she was making a difference. She wanted to collaborate with like-minded individuals. So we have to make sure that we're getting people who are passionate about the work and really engaged in what we're trying to do, I think.
Excellent. I love that. And also just popped a detailer recruitment quick reference guide that we put together here at NaRCAD. We also have job descriptions that are ready to go. You just need to put your organization's name in and make sure it matches what you're looking for in terms of the length of the intervention, what you're able to offer financially, and so forth. Thank you, Jess, for that. And another thing to remember when you're hiring is thinking about what skills do they need when we hire them, and what skills could be developed through a training. So again, making sure you're not expecting perfection when hiring. There may be somebody who shows already having a great foundation for communicating effectively, but perhaps they're not ready just yet to apply some of the skills they've yet to learn from coming to a training. So again, remember that we're your resource with getting people ready to get into the field, and that if you find someone who is trainable, we can help you get there. So that's something that really appreciate your question, Elizabeth. Please pop some other questions into the chat box. We have a little while longer. While you're thinking about other, yes? Ooh.
Hey, this is Suchin. I had to switch the phone because my internet died. But I wanted to add something to what Jess and Julia were saying.
Please.
We've had a similar problem where providers could make a lot more seeing patients all day, whether they're pharmacists or physicians. And we just didn't have a budget for any full-time detailers. So my team is actually like 4 or 5 different people who are all part-time detailers, and they spend the rest of their time seeing patients or providing clinical pharmacy services or what have you. But we found, especially because we sort of handpicked them, that the folks that are doing this maybe for 10 or 20% of their time, I mean, I think there's pros and cons of this approach, but they're super into it because otherwise they'd be maybe seeing patients all day or doing this work or that work. And so having a slice of time where they can do this, you know, pretty outside the box, interesting work of doing academic detailing, that's made the team sort of more diverse in one sense and also more sustainable because, you know, if one person's out sick or one person's out on maternity leave, we have a bunch of other people who are part-timers who can chip in. And though they aren't, yeah, I would say the most skillful detailers since they don't do it full time, it just helped us have more flexibility with staffing issues through the pandemic and beyond.
I love that. And thanks for continuing to keep us on our toes with where you're calling in from. So that's a great idea too, that if you can't pitch something effectively by saying, I can offer you the same salary you have seeing patients, which is unrealistic, to be able to say, how would you feel about just a couple hours a week doing something really different? So you're still making around the same amount of money, but it also breaks up the potential monotony, or as we've talked about before, and I know folks have been talking about today in particular, the burnout factor. You know, just being able to offer a clinician a change of pace. You know, Wednesday afternoons from 2 to 5, you get to get out of here and go on the road and meet with other clinicians like you. That can be incredibly validating for the clinician who gets to put on the AD hat. So that's a lovely piece of advice. Thank you, Shuchin. Lexi Hatch has some nice reflections here as well. For our AD program in Iowa, it was important to have detailers who knew the communities they served for the relationship piece. So we have all assigned regions we cover. Sorry, we all have assigned regions that we cover, and each of us lives in the region we cover. That's amazing, right? Because you don't want to go in, chat with a clinician and say, or, you know, appear that you have no understanding of what the population is dealing with. That's a great way to go in and, you know, kind of look like you haven't done your homework, and to have a clinician feel potentially defensive of, I know my community and you don't. So Lexi, I love that, love that. Tahira McClear says, part-time or contract detailers make a significant portion of our team, including myself. The benefits are you have your foot in the real world, you have connections in the clinical world, and as we mentioned before, it helps break up the day-to-day grind. Mike, I'm going to turn it over to you expand on your comment about building rapport, and also see if you have any questions up your sleeve. We've got a lot of great reflections here, but let's throw something over to one of these three panelists.
Sure. I mean, I think the point people are talking about with different models, it's there are definitely settings, and we've seen some at the conference over the years, for organizations that have full-time academic detailers, and that's great when you can support that, but there's a variety of reasons, and our panelists have talked about some of them, why that can be challenging. In terms of sort of making a virtue out of necessity, that part-time approach in the ways Shuchen talked about, if you're able to say as a detailer, in my clinical setting, even if you don't do exactly the same thing as the clinician you're detailing, you can relate to some of the pressures they face. You bring another perspective. All of that can be helpful, in addition to the flexibility that Shuchen mentioned. You can task shift a little and so on. And all of those are good things, really, at any time. I mean, we can all say, especially now with all the stresses on working life, but that's true several years ago, and it's true now. So I think that's really important. One of the interesting things when we think about the train-the-trainer model, and all of our panelists have participated as trainers for varying amounts of time, is you do have to train more people for the same volume of detailers. In other words, if you have, or the same number of full-time detailers. If you have one full-time academic detailer, you kind of train them once and upskill them, and that covers, however many hours a week full-time is. If you have a bunch of people doing it for, 10, 12% of their time, you might need to train several more people. And so to do that, you need more training capacity. And that's actually one of the things we've been thinking about in this whole train-the-trainer approach, is to make it more flexible. So I'd be really interested in reflections from the panel on either their thoughts or ways we could maybe build on this model. If you sort of get a regional expert and you said, we're not going to get one or two full-time academic detailers in our region, there's just not the flexibility, but we want to get a bunch of people trained up on this skill so that they can sort of flex time into it. Are there ways we can use this train-the-trainer approach to build on that? I don't feel like I have the vision fully worked out yet, but I'd love to hear from our panelists or others in the chat about how we can all sort of collaborate on building a vision for broader reach, more flexibility.
I love that, Mike, and I'm going to tee it to each of the panelists. And at the risk of being Captain Obvious, I want to say what Train the Trainer is and what we're trying to accomplish, just to make sure, because it sounds like it makes sense, but I know it took the home team a while to wrap our heads around exactly what it looked like. So the project we're working on, and the sort of model of Train the Trainer, which has become a bit of a buzzword in a lot of different industries, is the whole teach a man to fish, or teach a person to fish, rather than giving a person a fish. So if we were to train folks in how to be detailers, and those detailers are getting down into the field and doing well, we want them to train and be ready to train the next grouping of detailers. We at NaRCAD are not ashamed to admit that we are not detailers. We do not know what it's like to be in the field, other than from what you all tell us, and we take that as gospel. And so to be able, as Mike said, for example, to train some folks such as yourself to say, hey, we're a group of trainers who can train new detailers in the Pacific Northwest. We're a group who does this for a series of different programs in North Carolina. So these are the types of things that we're thinking about in terms of being able to do this with a formal curriculum and a process. So while we're working on that here at NaRCAD, and we're about halfway through our grant funding for this project, a little bit more, and we're excited to be able to share it with you in the not too distant future, I'm going to turn it over to Jess to sort of expand on Mike's question and reflections. When you're thinking about capacity building and being a trainer who trains new folks, what do you feel are some of the key pieces that make a model like this, or need to be there to make a model like this work and work well and be sustainable?
So the first thing that popped into my mind when Mike was talking was how here in New England, we're seeing a move away from smaller medical practices and providers joining some sort of a larger healthcare system, right? Whether they're joining Dartmouth Hitchcock or they're joining Catholic Medical Center or whatever this larger system of hospitals and healthcare providers is, I can see academic detailing having a spot inside that system and being able to take a trainer and train them to then go out into that health system and train other people from all walks of clinical life, whether they're PTs like Amy, who's coming into us, or pharmacists like Julia, or doctors, or NPs or PAs, to then go out and be detailers within that health system, because they already will know the people working in the system. They'll know who the medical director is. They'll know when the staff meetings are. They'll know how to get materials out to people effectively and what the rules are. So I can see that being a really great way to use a train the trainer model within a regional health system. I do think, and I'm a huge advocate, and Bevan, you know this, that in-person, face-to-face interactions where you get a chance to practice this kind of stuff is really super important. And if I was going to train people to do this, that's how I would really benefit from doing it. And I think they would get the most out of it too. I can't wait till we're back in person. I miss you all.
Same, we miss you too. I want to reflect on what you said. And part of the reason that it would be so fantastic is there is a lot of turnover in public health. I don't know if you knew that. There's a lot of turnover, and in particular because quite a few detailers, as many of you are funded under public health department, local and state public health departments. You know, funding changes quickly, areas of focus change quickly, and so the idea of going into a system where there is more of a fleshed out set of policies and procedures versus, you know, those of you who are going it rogue. The idea of being, you know, instead of building that structure all by yourself, which may take such a long time and be not realistic, to try to plug into a pre-existing structure of a healthcare system. It's a beautiful idea, Jess. And then also it becomes, if administrative staff is in on that, then when somebody leaves, you don't have to start all over. Those systems can understand how to scale up as well. So I love that. I'm going to turn it over to Shuchen if you are still here on your cellular device.
Here I am.
Here you are. Do you want to talk a little bit about capacity building through Train the Trainer and what you think would be critical to make it work either in your system or in general?
Yeah, I have a couple of thoughts, especially about what Mike said, which is great because I hadn't even thought of it this way. But, you know, I feel like what we've done here at my organization in Western North Carolina is sort of like maybe a guinea pig of this. I'm going to even venture a new kind of term for this, of a hub and spokes model, right? So like maybe NaRCAD is the hub where like all the newest evidence about academic detailing and all the, you know, like I saw in the program manual for the conference, the Inclusivity 101. So new content, new perspectives on doing academic detailing comes from the hub. There's a champion at each spoke. So my organization is a spoke. I'm the champion of the spoke where I stay connected to the hub. I participate in these conferences. I'm closely connected to the trainer, the trainers and the core team. But then in the spoke, I'm managing a team, in my case, of a bunch of part-timers who are clinicians, experts in opioid use disorder, and thus they know the geographic layout, they know the community, and they know the clinical topic. So I pre-game with them about new academic detailing sessions they're going to do. I debrief with them afterwards. I provide them like coaching and training. I myself do a little detailing just so I can stay abreast of what it's like. But really, then I'm running a team, and really we could expand statewide, which is what we've been doing in partnership with, for instance, the North Carolina Medical Board and various state level funders. And so I could see that being a way forward, or I mean, that is literally what we're doing. That's our way forward. Of we find funding, we're always connected to the hub to make sure we're doing this in a nationally kind of respected model, but then we're doing it with kind of boots on the ground, a local perspective on what are the local needs.
I love that. So what that means is, in your instance, you're serving as sort of the, can I call you middle management? Would that be okay? You're sort of the piece, the flexible piece in the middle. You're the railroad track that gets to shift. And so being able to be sort of the translator between those two pieces is just lovely. Thank you for that. Julia, I'm going to wrap up this question and reflections from Mike informing this question to say, what do you see as being critical to employing a train the trainer kind of model for capacity building?
I think a reminder and a recognition of the value of going back to the basics, whether you've been detailing for a year or for 10 years. I found it so beneficial going through this model and in the reference that you're producing to remind myself about adult learning theory. And then just breaking down the structure of a detailing visit. I've been detailing for years, but just having that reminder, okay, needs assessment, right? Deliver my key message, handle objections. Oh, what's the benefit of barriers, enablers? And we do that process during our training. So to have that reminder that sometimes we lose sight of because we're too busy going down the topic development path of what are we here to do? What are the practice gaps and how can we address it is something that this model sort of brought me back to after really not thinking about it for a long time.
That's a great point, Julia. We can get so focused on the application that we forget to go back and sort of say, are we still being informed by the original model? Are there pieces of this that we need to go back to and refresh on and polish up? And I think the real litmus test can be, could I teach this? Right? Could I teach this effectively? So these are all great ideas. I'm going to wrap up asking each of you one thing that you would want a new trainee, because you're all trainers. What's one thing you would want a new trainee who may be hesitant, not sure what training is about, especially for all of those in the audience who are new to this, and for those of you who are thinking of expanding your own teams and have already been trained? What's one thing you would tell somebody who is considering coming to a training who might be nervous or not know what to expect? Shushan, we'll get to you while we have you on the line. What do you think?
I'm a academic detailer built in evidence-based intervention. So I would just, push people to think, hey, you could give a lecture, you can provide other ways of doing CME for someone who needs to learn a new clinical skill. But if you do academic detailing, you're much more likely to have actual change in clinical practice. And so this is just a really novel skill set for most people who've been through medical school or pharmacy school of doing kind of adult education one-on-one, really reflexive of what the person's needs are. It's a new concept, so it's almost you have to unlearn some of the ways you've been taught of how people learn. But it's really effective, right? And that's why the evidence basis for academic detailing is so powerful.
Excellent, thanks. That convinced me. Jess, what do you got? What's something you'd tell a new trainee who's a little hesitant or unsure of diving into a training session?
So for me, being the non-clinical one on the panel today, part of my hesitance was, how is a doctor going to react to me coming in to say something about what they've had years of education and experience in when I don't have that? So as maybe a non-clinical person coming into training, it's important to remember that we're all just human beings, right? And if we meet people as human beings and we meet each other wherever we are, and we just go in and we are open to conversation and learning from one another, which is really, for me, what an academic detailing visit is. It's a give and take from one to the other. You can't lose. So come in with an open mind, come in with a willingness to learn, and share what you can bring as an individual to the table.
I love that very much. That's excellent. And, really getting back to the human to human piece, and this goes to what we talked about briefly yesterday around, am I expert enough? Do I know it enough? And again, just reminding yourself that it's just as much about how you communicate as what you communicate. And that saying, I don't know the answer to that, is okay. And also builds credibility. All right, last but certainly not least, Julia, talk to us about what you would convey to a new trainee about the benefits of training in AD.
Well, he stole a little bit of my thunder, but it is going to be uncomfortable at first, perhaps, because we're not used to communicating with our healthcare provider colleagues in this manner. So it's a new way of learning how to communicate and then feeling overwhelmed by the evidence and needing to know everything. You don't need to know everything. And it's okay to say again, I don't know, but know that it is such a rewarding job, and having those interactions with providers and knowing you made a difference, supported them with the information they need to provide even better patient care is just a great feeling, and building those relationships with them again is so rewarding. So at first it's a little uncomfortable, but no, it's definitely worth it in the end.
Amazing. It's all about building those rewarding relationships and showing that you are a service, tried and true, ambassador of the evidence. And Jess, thanks for wrapping us up with humor helps too. Yes, we don't need to be so serious about the evidence and so focused that we're not seeing folks as, another human who also hopefully uses some humor to get through the day. All right. Thank you all. We appreciate the three of you so much, and hope that those of you who are on the ground will get to a point where you may be able to come join a panel and share your own reflections quite soon. All right. So we're going to wrap up today, and we are going to move on to we also want to remind you to stay tuned for the Train the Trainer curriculum we've been working on here at NaRCAD over the course of a 5-year grant. So it's going to take you 5 years to read it. So hopefully you'll be ready by 2028. And we want to say thank you for a terrific day too. We're going to do the 5-minute wrap up and ask you another question. So Anna, what do we want to ask on the poll everywhere? And you can also type into the chat box.
Yes, so pull out your phones or type in the chat. What was the most valuable thing that you learned today? Norway rocks.
I hope, Ingrid, that you're still on the call to see that. What else? What's something that you learned today that felt really helpful? All right, I see. Keep it simple. Yes, don't overdo it on metrics. Networking. Yes, glad to see that. It's always tricky to network across a screen. How to pivot.
Oh, I love this one. There's no one right way.
Good information matters. That's also very true.
There's always more to learn. Lifelong learners.
Yes, and learning from each other. So important to consider that every person who's detailing has a different lens to look through. What else, Anna?
Using pharmacy students and pharmacy residents as detailers, also nursing students or medical students as well.
I want to be like Iowa when I grow up. Whoever wrote that, can you please tell us more in the chat box? I want to know what that means.
I'm assuming that has to do with the breakout. I'm seeing this we're all in this together. This panel is an example of train the trainer in action. Ooh.
Complexity reigns, go back to basics, building a team, seek with genuine curiosity, using the facts, being practical. Let's do a couple more, Anna, and then we will go to our final question and wrap up with our evaluation.
Sure. I'm seeing networking again, improvise. Word clouds are a great way to engage during meetings. Yes, we love word clouds. Learning by teaching, be yourself, and add your own touch. Be an individual.
Yeah. Less is more when it comes to materials. I also see in the chat box, I was in Lexi and Darla's breakout, and they're awesome. Give folks a shout out. We really want to encourage each other to teach. And last but not least, bring your own unique skills. All right, we're going to go do one more. What are you hoping to learn about tomorrow? And that's a little carryover from the prior poll. I see crazy heavy. Those are probably from the word cloud, asking what our year has been like. I don't know where these are coming from. Yes, what are you hoping to learn tomorrow? I think this came from what was your year like earlier in the day, because I hope you're not hoping to learn how to be funky or bananas tomorrow, but we can make that happen. One more time in the chat, or maybe this just isn't working. Okay, let's go over to the chat box This isn't working for us today. We're stuck on an old question. Go ahead and throw something in the chat box that you'd like to learn about tomorrow while Anna walks us through the day 3 agenda.
It just says, what was that about humor? All right, day 3 agenda. So I cannot believe that we're coming to a close on day 2 and we're about to head into our final day of the conference. Tomorrow is a full day that you definitely don't want to miss. After our kickoff, we will be joined by Carla Foster, who will present on an anti-racist healthcare campaign that is being developed in New York City. Then we'll have a plenary where we'll hear from several of the Veterans Health Administration's academic detailing projects. We'll have a break, and then we'll do one of my favorite sessions at the conference, which is the 2022 yearbook, where we'll hear reflections from successful AD programs. And then we'll have a break before heading into our final session of the conference, where we will be able to do some networking, and we will host a virtual roundtable and have some small and large group discussions. We'll wrap up day 3 with a reflections, closing remarks, and evaluations. So thank you all so very much. And I believe we can reflect on some of the chat, and then we'll talk about the evaluation, Bevan.
Yes, absolutely. Just seeing what folks are looking forward to. I'm sorry to disappoint you, Charles. We do not have a real yearbook, although if we did, I would sign yours something yearbooky, like have a neat summer, even though it's November. Seeing folks asking about, is 2023 going to be in person? Yes, we really, really want it to be, unless something comes up in the world of epidemics, but I'm already doing spells to make sure that doesn't happen. So yes, hopefully you can come to Boston, get some cannoli, we can shake hands, it'll be great. We can have some water cooler talk. But in the meantime, want to turn it over to Anna to invite you to fill out our survey. We didn't have as high of a response yesterday as we hoped for. We really want to know what you need from us, what worked, and definitely what didn't. So don't be shy. Anshul is about to drop the link right into the chat box. If you can click on that and start filling out your survey, it shouldn't take you more than 3 minutes. So if you can afford us those minutes, we would be so grateful. It's invaluable to us. And Carrie wants to catch a Bruins game. Yeah, that sounds good. I don't know about sports. I think they're playing now. So hopefully they will be playing in a year. Anna, anything you want to add to this? You want to talk about the raffle for a second?
Sure, yeah. If you fill out the evaluation today, you will be entered into a raffle for $250, donating your name to a public health charity. We're doing this each day of the conference, so a raffle for each day. So if you fill out all 3 days, the evaluations for all 3 days, you will be entered into 3 raffles for that. So please do fill out our evaluation. We got some really great narrative feedback yesterday, so please keep that coming. Thank you for that. And yes, we would love to get our evaluation numbers up. We do read every single one of your responses, so please let us know how it's going.
All right. Jess is roasting me in the chat box. I said I don't like cannoli because I prefer chocolate, and she said, duh, you can get a chocolate cannoli. So please all be prepared to come to Boston next year so you can school me, the Bostonian, and what I can eat in my own city. And to say our team really wanted to create not just incentive for you to fill out these evals, but hopefully feel good about filling them out. Because over the course of the 3 days, we'll have $750 to donate. We'll give you a list of public health focused charities, as Anna said. So again, please take your time and fill it out. If you don't want to be entered into the raffle, you can fill out your eval anonymously. If you have your eval open, you are welcome to sign off. If you want to stay on and chat with us, you are welcome to stay on. Mike, any closing remarks as we wrap up today?
Just gratitude for what a remarkable group we have. It's really terrific to see the energy, the fact that the chats and the questions are sort of spilling over the time, which means I'm spilling over the time, so I'll stop talking. But thank you for your energy and enthusiasm. And as Bevan said, we're in the early part of this year, coming off Omicron, things were just uncertain enough that we couldn't couldn't pull the trigger on in person when it was in the wind, but we are so excited to see you in person again.
We really are. We really are. All right. We'll talk to you soon. Feel free to sign off. Have a wonderful rest of your day, and we will see you at 10:30 EST tomorrow for day 3. Take care. Let us know if you need anything, and have a great night.
Bye, everyone.